It is requested to all the speakers of the session to kindly submit their presentations before the session. If there is a problem, we can proceed to the second presentation. मल्टीमीडिया वाले करेंगे
Good morning everyone. Assalamu alaikum. Today my topic of presentation is technical report of freehand pedicle screw placement using Kim's entry point for lumbosacral spine. I'm Dr. Nadia Banaras, working as a senior registrar at Civil Hospital, Quetta. Okay, as we all know, the freehand insertion technique relies on the tactile feedback of the surgeon and the use of the anatomical landmarks to pass the pedicle screw with the limited or no use of the C-arm, okay, and the navigation is absent in this case. It's ideal for reducing the intraoperative radiation exposure, reducing the overall operative time, and also to provide the streamlined curve for the young neurosurgeons to learn. What was the objective of my presentation? The different methods for lumbar pedicle screw have been advocated. I am talking about for the freehand. The different kinds of the entry points have been advocated, and each technique has its own cons and pros. If you talk about the Kim's entry point of lumbosacral pedicle screw with freehand technique, we want to know what is the accuracy of this technique for passing the freehand screws. Okay, to explain my presentation, get a short review about the Kim entry point. Whenever you are dealing with the freehand surgical technique, what you should know is that you should know about the superior articular process, the transverse process, and the pars interarticularis. If you can see into the presentation, okay, if you can see, the A point is showing the Kim's entry point, that is junction of the proximal process of the transverse process with the inferior lateral edge of the superior articular process. However, the other points like Royal Camilla and Edward methods are the other entry points which are used by the other surgeons to pass the freehand technique, freehand pedicle screws. If you can see in this diagrammatic presentation, we have shown the trajectory. For the Kim's entry point, the best thing about is that we use little angulation, 5 to 10 degree medially because of this position, and we have to go craniocaudally just parallel to the superior end plate, and we are just in the body. So the question is that whenever we do a research, why KIMS, why not other, the Camilla technique, the Royal Cathode method, why not those others? We have 3 points in favor of this. It requires the minimal change of angulation, as I already explained. It is situated more medial as compared to the other techniques, and it's situated exactly posterior to the pedicle. So the cranial counterangulation is not a big deal in this case. We have done this study retrospectively. We examined 118 cases from the January 2019 to December 2022 in the setting of Department of Neurosurgery, Bulan Medical Hospital. We assessed our data through SPSS 22. The most important thing, what the patient were included and what the patient were excluded. We took all the patients who were between the age of 80 and 70 years, presented with the complaint of lumbar back pain, and any type of spinal pathology, including degenerative, trauma, and METs. And what we excluded, the patient more than 70 years of the age, the previously operated patient, and the patient, especially, they were present with a concomitantly spinal deformity. We are not dealing, as it's not easy to pass the pedicle screw with freehand in the patients who have kyphosis and scoliosis, so we exclude them. Okay, the most important is that, what was the gender prevalence? We have more females as compared to the males. As you can see, the 62%, 76% females as compared to the 62% males. Let's talk about the spinal pathology, what we faced during our study. The degenerative was on the topmost, followed by trauma, and then METs. If we talk about how much the number of the pedicle screw, in total we have passed 706 pedicle screw, and the most common level, it was L5, in which 24% pedicle screw were passed, followed by 22% in L4, and S1 was 15, and then the least one were L1 and L2. Our results, what was the accuracy of our pedicle screw with complication? If you can see, the accuracy is, I wish I could say, the accuracy was 94.5% as compared to the complication, that was 6.50. There was a great learning curve, like 94.5 was a good thing for the centers where we don't have the good facilities like neuronavigation. If you see, the complication is a part of every surgery, even if it's done in a good center where the neuronavigation is available, or even if it's a center where just simple C-arm is available, and even the no C-arm is available. So the complication, we divided into 3 parts. The repositioning was done during the surgery. Like we were passing the screw, and if we have the feeling of giving away, so we reposition the screw with the help of the C-arm sometime to make it like where was this. Then the breach was 1.5%, and only 0.20% we have to remove the screw. And talking about the breach, we take a safe zone of 2 to 4 millimeter, the safe zone in case of pedicle breach, because with the 2 to 4% millimeter, there was no nerve root in irritation signs. If I talk about the vertebral level with complication, like we passed the 706 screws in the different vertebral levels, and the percentage of the complication was more occurred in cases of the S1. And you can see the breach is 3.10 in cases of S1. The most common thing was that like KIMS entry point, that was like we adapted from the Korean journals. They have firstly used in 2013 and back in 2005. They were just limited towards the lumbar spine. So we advanced it towards the sacral spine. And we could know in sacral spine, the entry point quite be different. So we have the breach issue with sacral spine. That was 3.1% and 8.1% we have to reposition. So in short, the freehand pedicle screw placement based on our external landmark of the proximal junction of the transverse process with the superior articular process is acceptable safety and accuracy. It's cost-effective, avoidance of the radius exposure, and prolonged operative time. These are some of the post-op X-rays. Thank you for your attention.
Thank you very much for excellent paper. The second presenter is Dr. Mohammad Farooq Sherzada. He will talk about transforaminal discectomy under local anesthesia, my experience. We will take the question answer session at the end of this scientific session.
Bismillahirrahmanirrahim. Assalamu alaikum. My topic is transforaminal discectomy under local anesthesia, my experience. About me, I am Dr. Farooq Sherzada, working as a consultant in Peshawar, and I started my endoscopic spine journey in 2017. If you look at the history of transforaminal endoscopic spine surgery, so they came in 1990, who was the first to introduce anatomical understanding of the transforaminal approach and triangular safe zone, where a lesion can be approached without a neural damage. Then the Young, who developed a full endoscopic spine surgery with consent irrigation and named it as a YES system, and he did a transforaminal surgeries. Then in late 1990s, Rutten et al. Work on full endoscopic interlaminar and transforaminal approaches. So the aim of endoscopic spine surgery is to provide a safe and targeted access to a compressive pathology with a minimal soft tissue trauma while performing decompression and or fusion. If we look at the evolution of surgery for lumbar disc herniation, so initially there was a bigger access to a disc herniation. Then with the passage of time, now we do a percutaneous endoscopic discectomy with the smallest access. So there are two important points in doing transforaminal endoscopic discectomy. The first one is epidural scarring. So scarring is the neural healing process followed by a spine surgery, but it is frequently associated with failed back surgery syndrome. So you can avoid epidural scarring and transforaminal surgery. And the other most important structure is multifidus muscle. It is a major posterior stabilizing muscle, and it primarily responsible for a dynamic stability of lumbar spine. So full endoscopic spine surgery have two routes. One is interlaminar and the other is transforaminal. So you all should know about the Campbell's triangle before starting the transforaminal approach. And it is interior bordered by the exiting nerve root, inferior bordered by end plate of the lower vertebra, posterior bordered by the SAP of a lower vertebra, and medially bordered by traversing nerve root. Transforaminal endoscopic discectomy is perhaps the most difficult and the most important endoscopic procedure to learn. Why it is most difficult? Because of the different techniques and inconsistent teaching. Patient selection is critical to overcome the learning curve. You need 25 cases directly supervised to learn the transforaminal endoscopic discectomy. Why we should master endoscopic surgery? It is the least invasive discectomy approach currently available. No bone or phlegm removal, no root retraction. It's the first step toward a much wider application of the transforaminal approach, which is the most stability preserving, nerve protecting, adhesions preventing, and adhesions avoiding approach. So the contraindication for transforaminal endoscopic surgery is S1 PIVD in a male patient with high iliac crest and high-grade cranially migrated disc at any level. Aside from these, any disc hernia in the lumbar and thoracic spine can be safely and effectively removed by a transforaminal approach. Before doing the transforaminal approach, you have to carefully look at the X-ray and the MRI to see the foramina, size of the foramina. So don't get confused. Do few cases for L4-5 paracentral, non-migrated, then fill in the gaps by expanding the indication, that is other level, migrating disc, far lateral, recurrent disc, and cases with the tight lateral recess. Basically, a transforaminal surgery is a tale of two nerve roots. You dock on the lower part of the foramina, then you follow the traversing nerve root, and then the exiting nerve root, and the disc is just between these two roots. The key steps in the tail is the most important is a needle entry point and needle landing point. And then sometime you need to ream the SAP. And then endoscopically identification of the compressed nerve root to safely find and completely remove the disc fragment. Here is some article which shows that the tail under local anesthesia offers several advantages, and it is especially beneficial for elderly patients with poor general health. Another study shows the procedure represents a significant step forward in the field of minimal invasive spine surgery. TEL can be performed under local anesthesia, making it a patient-friendly option. So it is a routine setup for endoscopic spine surgery, OT setup. Anesthesia, local anesthesia with conscious sedation is most preferable. No general anesthesia, epidural, or spinal anesthesia. As introduction of endoscope in Campbell's triangle having exiting nerve root very nearby, so chances of injury may be more if general anesthesia given. Position of the patient is prone. The most important thing is to calculate the entry point. So you need an AP image for 2 lines. One is spinous process line and the other is discal line. Then you turn your fluoro to the lateral and draw a disc inclination line, which is the line from the interior of the vertebral body to the surface of the skin, and then measure this distance. And this is basically the measurement of your entry point from the midline. The landing point should be inferior of the foramina, and you check it on the AP that the needle should not exceed from the medial pedicular line on AP and the posterior vertebral line on lateral images. Why medial pedicle line? Because dura is 1.5 to 2 mm away from the medial pedicle line. In initial, you need to do a discography, but it's optional. Then dilator insertion, then cannula insertion, then put the endoscope and identify the anatomical landmarks. As you can see in this video, when you put your, I think video is not working, and then disc removal. So confirmation of decompression is a free fluttering of the annular flap and epidural fat, and you also ask the patient to cuff if there is easily pulsation along the traversing nerve root, so it is the end point of the decompression. So my study design is the retrospective case series study. Sitting is Dr. Farooq Neurospine Institute of Regional Medical Complex, Peshawar. Study duration 4 years, sample size 67. It is non-probability convenience sampling. The inclusion criteria is patient operated through endoscope transforaminally under local anesthesia. And exclusion criteria were patient diagnosed with condition other than disc herniation, operated under general anesthesia, and the procedure is full endoscopic transforaminal discectomy. Follow-up period is 7 post-op, 3 months and 6 months. Among my patient, majority are male, and the age distribution is 46 to 60% occupational medical professional, and the duration of the symptom is majority is 7 to 12 months. If you look at the outcome in the term of back pain, vaginal lung scale, so there is a statistically significant reduction post-operatively. And if you look at the outcome in term of leg pain, so you can see statistically significant decrease in the post-operatively. Outcome in terms of SLR, pre-operatively the mean is 30, and 7 post-op day, 3 months post-op, and 6 months post-op is 90. Reported complication, infection in 1%, 1 case, nerve injury 1, which spontaneously resolved after 2 months. Recurrent herniation is 2. So the complication rate of different discectomy technique for symptomatic lumbar disc herniation, a systemic review and meta-analysis conclude that open discectomy and micro discectomy results. The pill has a lower risk of oral complication and a lower risk of complication necessitating conservative treatment. Another article which shows the learning curve of full endoscopic lumbar discectomy, it concludes that the transforaminal approach was steep and easy to learn, while the learning curve of the interlaminar approach was flat and hard to master. So these are the MRI. Patient presenting to my clinic with L4-5 paracentral disc herniation. I did transforaminal approach to this patient and local anesthesia, and post-operatively you can see the post-op MRI. So this is the beauty of the endoscopic spine surgery, that bilaterally you can see the paraspinal muscles, the ligamentum, flavum, facet, and everything, each and everything is safe. This is another case, L4-5, upward migrated disc, did transforaminally, and you can appreciate the results on the post-op MRI. So these are my research articles regarding the endoscopic spine surgeries. And take-home messages, our study highlights the potential for significant improvement in pain, disability, sensory and motor function, ranges, and overall satisfaction of patient after undergoing transforaminal endoscopic lumbar discectomy under local anesthesia. While complication may arise, careful selection and skillful surgical execution can minimize these risks. In conclusion, transforaminal endoscopic lumbar discectomy under local anesthesia is a valuable option that can lead to a better patient outcome, but individual cases may vary. A thorough understanding of patient characteristics and post-operative management is crucial for a success. And thank you.
Thank you very much, Dr. Farooq, for the excellent talk on endoscopic discectomy and this innovative technique.
May I request the next speaker, Syed Hanifullah, to discuss their experience of antibiotics for laminectomy and fenestration procedures. Syed Hanifullah. Okay, moving on to the next presenter, Dr. Burhanul Haq. Dr. Burhan will discuss his experience of short, same segment fixation in thoracolumbar spine traumatic fractures.
Bismillahirrahmanirrahim. My name is Dr. Burhan. I am resident of neurosurgery in Combined Military Hospital, CMH Lahore. The research work under scrutiny is based on an experience of thoracolumbar fracture management at CMH Lahore between June 2022 and 2023. This is our team. So some 20 cases have been singled out for this study, which lays emphasis on the efficacy of short segment thoracolumbar fixation for the fractures with the inclusion of intermediate fracture vertebra in the construct. So on a glance, thoracolumbar spine spans by definition from T11 to L2, and nearly 60 to 70% of all the fractures occur at this level. And due to significant axial loading forces, flexion and distraction forces, fracture can be caused as a compression injury or a distraction injury or a torsional injury. Compression and burst fracture without a neurological injury are often managed conservatively with lumbosacral extension brace and early mobilization. And surgical intervention may be required in those fractures with associated neurological injury and instability. In some patients with difficulty in tolerating brace, surgery is also advocated. The treatment goals are usually biomechanical stability, decompression of neural elements, sagittal alignment, kyphotic correction, early mobilization, and pain relief. So the objective of my study is to evaluate the effectiveness of including the fracture vertebra in the fixation construct in the thoracolumbar spinal fractures, and also the effectiveness of using fewer number of spinal levels in the construct, shorter construct, and overall clinical outcome of this technique. So this is a sample size of 20 patients with a male preponderance having monosegmental thoracolumbar fractures, single level fractures were chosen. They were managed with short segment posterior fixation between June 2022 and 23, and the range of ages was 22 to 74 years with the mean age of 42 years and standard deviation of 16. Radiographical, clinical, and surgical indices and outcome were noted as a part of a prospective study. All the patients were operated within 14 days of admission and underwent radiographs and CT scans of the thoracolumbar spine for the evaluation of fracture pattern and pedicle integrity. Pre-op MRI were assessed to assess neural canal involvement. Radiological indices were recorded from the pre-op, immediate and post-operative and follow-up scans of the patients under scrutiny, and to assess the functional outcome in terms of pain, visual analog VAS score was obtained on follow-up. Neural assessment was done as per Asia impairment scale. To classify thoracolumbar fractures, AO Spine, McGarrell et al. thoracolumbar spine injury classification was used, which uses generally type A, type B, and type C grossly compression, distraction, and translation injuries, as described in this picture. A brief overview of the pain scale and Asia scale. My inclusion criteria was only single level fractures, and the fractures who presented to us within 2 weeks of the injury, the unstable fractures with vertebral body height loss of more than 50%, and that may be with or without the involvement of PLC. The patients who underwent short segment fixation, including the fractured vertebra. The exclusion criteria were severely osteoporotic patient, the patients with severe medical illnesses that precluded operative treatment, associated extremity or pelvic girdle injuries, pathological fractures caused by metastasis or infection, burst fractures with retropulsion into ankylosis, and all the cases were operated in a prone position with standard midline approach. With the exposure of lamina and facet of the intended segment, pedicle screw fixation was done, followed by fluoroscopic checking. Instrumentation, including bilateral screw fixation, was done into vertebra above the fracture, the vertebra below the fracture, and through the fractured vertebra. The metal rods were connected with the screws bilaterally on either side of the midline. In the cases where there were broken pedicles, the screw was not introduced into the broken pedicle. Indirect decompression with ligamentotexis was carried out, provided that the surgery was done within 14 days and the canal is not severely compromised. And for the cases with canal compromise and disruption of posterior ligamentous complex, direct posterior decompression was done, and the retropulse posterior fragments were pushed into the vertebral canal through a posterior approach. Postoperative mobilization was allowed in all the patients wherever tolerated. Rigid lumbosacral belt or brace was applied for 8 weeks or more post-surgery. Successful surgery was defined as pedicle screw finally implanted with satisfactory reduction and restoration of vertebral height. Methodology, we used radiographic indices from the radiographs, including segmental kyphotic index, including the fracture vertebra, the Cobb angle, and the anterior vertebral height ratio and the vertebral loss. This is how we measured the Cobb angle and the kyphotic angle. The vertebral height was calculated by measuring the distance of the vertebral loss anteriorly. Local kyphotic angle and Cobb angle. This was the demographic data of our work. The mean age was 42 with 15 standard deviation. There was a male preponderance with 90% males and 10% females. 4 patients were having A4 complete burst fractures. 14 patients had A3 fractures. 1 patient had B1 translation injury. 1 patient had B2 injury. Fracture levels, 1 patient had 11, the fracture at T11. 4 patients presented with T12 fracture. 6 patients had L1 fracture. 7 patients had L2 injury, and L3 fracture was found among 2 patients. 95% of the patients were neurologically intact with Asia E impairment scale, and 1 patient was Asia C. The average duration of the surgery after presentation was 6.6 with a standard deviation of 2.2. This is the radiological outcome that we observed on this, So the mean Cobb for these 20 patients preoperatively was 15.56, and the segmental kyphotic angle was 21.19, and the vertebral height loss was 53%. And at 3 months follow-up, there was correction of Cobb from 15 to 5.873 average, and segmental kyphotic angle was improved from 21.19 to 6.34. with a vertebral height restoration of about 85.64%. At a final follow-up of average 7 months, the Cobb angle was 7.78 on average, and segmental kyphotic angle was 5.9, and vertebral height loss was 87.7%.
Dr. Burhan, you have 1 more minute left. Please wrap up.
So results, thoracolumbar fixation was done in 20 patients, of which 18 were males. 6 patients were lost to follow-up after 3 months. Patients were monitored until 7.3 months. 5 patients improved after 1 grade of Asia scale on surgery. Most patients showed good improvement of pain and function after surgery. The preoperative pain level on the VAS was 7.6, which improved to 4.2 after 3 months of follow-up and 2.5 at final follow-up. Mean operative time was 123 minutes and mean post-operative hospital stay was 9.9 days. Mean pre-op SKA was 21. Mean pre-op COB was 15, which improved to 6.0 and 7.3 respectively. Mean loss of kyphosis correction was 1.9. The final follow-up vertebral loss was 12.21 patient, excluding the patient who were lost to the follow-up. No patient developed post-operative surgical site infection, CSF leakage, implant failure, or screw breakage during the follow-up, and no patient showed neurological deterioration after the surgery. No patients required reoperation due to the implant failure or pseudoarthrosis. These were the few surgeries which we performed. D12 fracture with more than 50% vertebral height loss, restoration of height after the surgery, a B2 type injury in the LV1 fracture, post-op image, pedicle integrity was not there, so screw was not passed, and the patient neurology improved from Asia C to Asia B after surgery. LV2.
Please come to the conclusion. Your time is finished.
So, short segment fixation is more efficacious in lesser operative blood loss, fewer complication, cost effectiveness, lesser hospital stay, early mobilization, and confers more biomechanical stability to the thoracolumbar spine with significant reduction in overall disability and the pain. However, it is worth mentioning that more highly qualified randomized controlled trials be designed to guide the selection of best surgical approach in the patients with the thoracolumbar fractures. Thank you.
So our next speaker is Musaddiq Latif. He will be presenting on pattern of spinal injuries.
Thank you. Assalamu alaikum, respected seniors and dear colleagues. I am Dr. Musaddiq Latif, working as a senior registrar in the Department of Neurosurgery, Pakistan Institute of Medical Sciences, Islamabad, under the kind leadership of Professor Dr. Lal Rahman. And the topic of my paper presentation today is pattern of spinal injuries. So expansion in road network, motorization, and urbanization has been accompanied by a rise in polytraumatic cases globally. Spinal cord injury is associated with permanent disability and decreased life expectancy. So the objective of my study was to identify the pattern of spinal injuries in patients with traumatic spinal fractures, and somehow we came to discuss about the outcome of these spinal injuries as well. So the study was conducted at Department of Neurosurgery, Pakistan Institute of Medical Sciences, Islamabad, and this was a retrospective study which was conducted from August 2022 to September 2023. 134 cases was included in this study, and the data analysis was done through SPSS version 25. So all patients with traumatic spinal fractures were included in the study, and patients with osteoporotic and metastatic collapse, isolated transverse spinous process fractures, and penetrating trauma, ballistic injuries were excluded from the study. Young people are most commonly affected, as has been seen. The age group of 30 to 40, 53 patients has been included in this age group, and with the mean age of 32.9 years. And this has been compared with other studies which also show the same results. And males predominate the females, as we can see in this. 86 out of 134 cases are males. And this again corresponds to the other studies, other international papers. And motor vehicle accident is a major contributor. As we can see, 44.60% of total cases are admitted through the road traffic accidents. And this also corresponds with the other international studies. So the thoracolumbar spine was the most affected segment of the spine. And this we can see 40.20% of patients had presented with thoracolumbar spine fractures, while the next most common affected segment of the spine was the cervical segment. And in this, other studies show cervical spine fractures were the most common in those studies. So it was a compression fracture. Most common pathology we had seen in trauma spine was the compression fractures. As we can see over here, 56% of the spine fractures were the compression fractures, while the burst was the next most common. And this, we can see the most common fractures were at the level of the thoracolumbar spine. Then there were, and these are all the compression fractures. And the second most common level was affected was the cervical spine. 20 out of 40 cases in the cervical spine were the compression fractures. Out of 134 cases, 106 cases were operated, while the 26 patients were not operated. And outcome was assessed on the basis of the Asia grading, in that 34 patients, 60 patients were with compression fractures, and 11 patients in our study were with Asia grade, and 9 patients with Asia grade B, and 18 patients were with Asia grade C, and 26 patients were with Asia grade D, and 46 patients were with Asia grade D. However, we can see in this that there's some sort of improvement in pre-op and post-op cases, as out of 9 patients who had presented in Asia grade A, all were in all had improved. All were in the same grade after the operation. While we can see that the patients who had presented in Asia grade D who had improved to Asia grade E. So in conclusion, young age males are most commonly affected. Road traffic accidents is the most common mode of injury. Most common vertebral level affected is the thoracolumbar junction, and there's a significant association between complete spinal cord injury and fracture morphology. Likewise, distraction fractures have got the complete spinal cord injury, and those patients are presented with loss of power in all the myotomes. Thank you.
Thank you, Dr. Musaddiq Latif. Our last presenter for this session is Dr. Shabi Aisha. Probably presenter is not here. That should conclude this session.
So for question answer, I would like to request our worthy chairman, Professor Arif Malik, to take care of this question answer session and wrap up the session.
So I'll ask the presenters to come on the stage so that they can answer any relevant questions. First of all, I congratulate all the presenters to being precise and on time.
Any questions, comments?
Hello, 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 hello. Hello, hello, hello. Hello, 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 hello. Hello, 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 hello.
Assalamu alaikum. Dr. Farooq Shahzada, it was a wonderful presentation. And I'm astonished to know that you are doing it under local anesthesia. My question is, when you manipulate with the nerve roots, does a patient feel any hesitation or pain or some discomfort during manipulation of nerve root under local anesthesia?
Actually, I take 2 10 ml syringe, and when I take 4 ml how are you? I anesthetize the skin and the part of our distraction. And then once I hit the foramina, then I give 2 ml of the everything in this one rise. So if there is any non-articular part of the SSC, that is interior part of the SSC. So you can remove it, then you can see the exiting nerve root. So the indication for the transforaminal endoscopic spine surgery is central disc herniation, paracentral disc herniation, lateral disc herniation, foraminal extraforaminal disc, and remove the disc, either it is upward migrated or downward migrated.
Right, thank you very much.
Because for stenosis, you have to go through interlaminar approach and you do a over the top decompression. So for any type of disc herniation, you can do a transforaminal discectomy, either central, paracentral, foraminal, and extraforaminal.
Right. Thank you very much.
Nadia. In the present day of awareness of the patients and the media and social media and all that, if perchance you get a complication of placing a screw by freehand technique and you are sued in the court or you are go into the healthcare commission, how will you justify yourself? And you may land in hot waters depending upon your decision of operating without image guidance.
Like in Equita, if a patient is coming to us, we've making sure that this can be happened with the C-arm, neuronavigation. We give him all the options. If the patient is is agreed with us, then we will go for that surgery. And you see, we have just in 0.02%, we have to remove the screw. There were just 2 screws. Most of the patient, we does not need to reoperate, to do any kind of the nerve injury and any kind of the decompression post-operatively. We have never have done that. So it's just the base of the skill and it's base of the steep curve. We are quite confident in that and we are quite comfortable with that. So that's why we are using the freehand technique. It's a best idea. If you see, it's a best idea if you don't have the resources. The neuronavigation is not prevalent in very less cities of Pakistan. And if you talk about even the C-arm, with the C-arm, it's also a freehand technique. With the C-arm, it's not like something different. Just you are using the C-arm or not it's a slight different thing. But with neuronavigation, it's a quite different thing. And neuronavigation is not prevalent in the other cities as well. So why not with the freehand? Thank you.
Any
So
questions?
with this, we come to the end of the session.
Thank you. Now we proceed to distribution of shield and certificates. So I request the GS to please come on the seat. Dr. Zubair Tahir. Dr. Zubair Tahir. Dr. Nadia, please come on the seat. Dr. Farooq. Dr. Farooq Shahzada. Dr. Hanif Lepser. Dr. Burhanul Haq. Dr. Musaddiq Latif. Jaldi kar. Come on. Dr. Sabi Aisha. Jaldi kar. Next. सर आपकी
नाम लेना
वो मैं आपको दे देता हूँ distribution to the chairman. Sir, please. ये आपकी है, sir. So now we proceed to next session. I request the chairman to please come on the stage. Professor Abdul Hamid, Professor Lal Rahman, and Professor Shahzad Hussain.
We are studying our next session. I would like to call upon Professor Dr. Zubair Tahir from UK. His topic of presentation is spinal dystrophism, embryology and development.
Thank you, Chair. Can you project my slides, please? Right, so let's kick start. Why talking about spinal dystrophism is important? I've got three reasons to begin with. The first, I will start with quoting Dr. Lal Rahman's paper on spinal dystrophism, where he showed us that the incidence of open neural tube defect
pattern, they have got vertebral segmentation problem, neuroenteric cyst, or associated deformities. When we do imaging, we can see that there are primarily two types of split cord malformation. In type 1, we have got a bony spur along with low-lying spinal cord, and you can see that there are two dural sleeves with spinal cords, and the type 2, there is a single dural sleeve with two spinal cord. The reason it is extremely important to have differentiation because the natural history is different. While type 1 children require spinal cord untethering, on the other hand, asymptomatic child with type 2 split cord malformation should be managed conservatively. Now, trying to explain that on the basis of gastrulation, as I mentioned earlier, this is the stage where there is a formation of the middle layer, and during that process, there is ectoendodermal adhesion. And as a result, there are two compartments rather than one. So we end up with two heminotochord that leads to the formation of two spinal cords. Whether this will be type 1 or type 2 relies on the position of meninx primitiva cells, whether there will be a single dural sleeve or two separate dural sleeves. Now, when it comes to the surgery for split cord malformation, as we all are aware, you start with extradural removal of bony spur, but that is just the iceberg. It is important that we proceed with our dural opening, and as you can see here, we started dural opening cranially, then you work around the bony spur, and then intradurally you see the rest of the bony spur that needs to be removed using standard microsurgical techniques. Once the bony spur has been removed, then you proceed with dividing the distal end of the phylum and achieving complete spinal cord untethering. It is important that bony spur should be removed first before we do untethering of the distal end. Otherwise, there is a risk of crotch injury to the spinal cord. And of course, this will be done with intraoperative monitoring. This is a book which I will definitely recommend, focusing on spinal dystrophic malformation, and the chapter which we publish is open access to everyone. Now, primary neurulation failure leads to open neural tube defects or myelomeningocele. These are the children who are born with leaking CSF, spinal cord malformations. Some of them, they have got macrocephaly due to ventriculomegaly at the time of birth. Now, going back to the embryology, as you can see under the influence of notochord, the ectoderm forms the neural plate. On each side, the neural folds arise upward and they join together. And this is what we call tube formation. And failure of that tube formation leads to the spinal dystrophism, which is myelomeningocele. It is important to understand that this is not just a spinal pathology, but a pan-CNS problem, and hence we often see associated malformations intracranially, like cerebellar tonsillar ectopia consistent with type 2 Chiari malformation, beaking of tectum, ventriculomegaly, and interdigitation of gyri and sulci. So the management, as we all aware, soon after birth, you clean the placode with the warm saline, you put a non-adhesive dressing followed by saline-soaked surgical gauze and wrap with a cling film and nurse prone while the patient is waiting for surgery. Ideally, this should be repaired within 12 to 24 hours, and the surgery requires careful dissection of placode followed by neurulation of placode, dissecting the dura and covering it in the midline, raising the myofascial flap, and then skin closure. So essentially a multi-layered closure. That was the standard of care, which is the postnatal management, until the publication of this landmark paper, MOMS trial, in 2011 in New England Journal of Medicine, which clearly showed that prenatal surgery improves the chances of them not requiring shunt after surgery, and that risk is reduced to 50%, with additional 2-level motor benefit. As a result, we started fetal interventions about a few years ago. There are two primarily different approaches. Either you can do it with open or using fetoscopy. Now, quickly showing you one of our cases. So the standard exposure of uterus, and then with ultrasound scan, you try to map the attachment of placenta. The first step is to take a deep stitch so that you can anchor the amniotic membrane with the uterine wall to avoid the premature rupture of membranes. Then you start with opening the uterus, and then you float the fetus into your exposure and do your standard multi-layered closure of open neural tube defect. Now, with primary neurulation, there are two steps. One is the formation of the tube, and the next is the disjunction of that tube from your cutaneous ectoderm. A failure of disjunction leads to persistent tracts, which we can see. These are the babies who are born with punctum on their back, skin tags, or human tails. And as here you can see, that's the tube formation. But what happens, there is a persistent cutaneous tract, and that leads to formation of either dermal sinus tract or limited dorsal myeloschisis. So often these tracts are associated with intradural dermoids, and if not picked early on, that can lead to significant morbidity because of infections. Here is a case where we performed a resection of the tract along with dermoid. You can see the dermoid compressing the conus and chorda equina. Once the specimen was removed, you can see you removed it as a single piece. So this starts from the skin lesion and then proceeds with the subcutaneous tract, intradural tract, finishing all the way to the dermoid. Now, what will happen if the tube separates from the cutaneous ectoderm without completely closing? And as a result, that leads to the formation of spinal cord lipomas. These are the skin-covered lesions, and as you know, there are three types of spinal cord lipomas: dorsal, transitional, and terminal. Here again, showing the formation of the tube, which is primary neurulation, but what happens that the tube disconnects from the cutaneous ectoderm, and the fat cells infiltrate the spinal cord, leading to the formation of spinal cord lipomas. The surgery requires radical excision of spinal cord lipoma with intraoperative neuromonitoring, followed by neurulation of your spinal cord, and offering an expansion duroplasty to increase the cord-sac ratio in order to reduce future tetherings. We have done multiple publications, and probably we have closed the debate of what is the best strategy. And if you look at these Kaplan-Meier curves, out of three options, radical excision, partial versus conservative, the patients who did worse were where the partial resection was attempted. In fact, the partial resection was worse than the natural history of the disease. So either you don't operate on them or go for radical excision of spinal cord lipomas. The last clinical example with the secondary neurulation defect is terminal myelocystocele. These are very complex lesions. These babies are born with large swellings on their back, which are filled with CSF. And if you do MRI scan, what Dackling Pang describes a seal within a seal. So you have got two CSF cavities. One is the subarachnoid space, and second is your distal spinal cord opening into a big trumpet. Going back to the embryogenesis, as we all know that during secondary neurulation, there should be the degeneration of the distal spinal cord. However, on the other hand, that process is hindered, and you see the extension of spinal cord outside the spinal canal, and the distal end of the cord balloons up like a trumpet, and this requires careful mapping. This is an example of surgery where you can see that the dura expanded as well. After your durotomy, starting from the normal to abnormal, you see the dorsal root entry zone and the trumpet attached to the subcutaneous fat. And here we are mapping the trumpet to understand our demarcation, where we will do the spinal cord untethering. And at the end of the surgery, you are in fact looking inside the spinal cord. You proceed with neurulation of that stump, followed by expansion duroplasty. Now, this is the most important slide showing how we can understand all these dystrophic conditions under the umbrella of embryogenesis, starting from formation of the trilaminar disc, which is gastrulation, then neural tube closure, which has got two components, a formation of tube and disjunction of tube, and lastly, the secondary neurulation. So the take-home message is that spinal dystrophic conditions are very heterogeneous, and understanding of embryogenesis helps us to devise a management plan, which essentially depends upon whether these are CSF leaking or closed dystrophic condition. Children who are born with closed dystrophic conditions, they should be managed electively with MRI scan and preoperative bladder function assessments. Intraoperative neuromonitoring, I think at least for us, is mandatory for occult dystrophic conditions, and the approach is multidisciplinary, and I'm very fortunate to have a great team with my colleagues Dominic Thompson, Declan Peng, not only but neurophysiology, urology, nurse specialists, and our team of physiotherapists. Thank you for your attention.
Thank you, Dr. for a very nice presentation. Our next presenter is from Turkey. That is from the Department of Neurosurgery, Marmara University Medical School. And the presenter is Ozan Sonmez. The topic of presentation is analysis of relationship between subaxial pedicle screw malposition and vertebral artery injury in this categories.
Bismillahirrahmanirrahim. Assalamu alaikum. I am Dr. Talha Rashid, resident of neurosurgery in Punjab Institute of Neurosciences, Lahore. And today I am here to present the paper presentation on the outcomes of minimally invasive spinal surgery done in our setup. Thoracolumbar region is the most susceptible area in spine trauma. About 75% of spine trauma occur in this region because this is a transitional zone from thoracic area to flexible lumbar area. According to the AO classification, thoracolumbar injuries have been classified into 3 types: type A, type B, and type C. We did our descriptive case series studies in which we selected 90 patients who fall into the category type A, most precisely type A2 to type A3. Initially, such type of spinal fracture managed surgically by conventional open transpedicular fixation, but with recent advancement in surgical management of spine trauma, the minimally invasive spine surgery MIS have overcome the conventional open TP fixation. Most common MIS technique we use in our setup is percutaneous screw pedicle screw. Multiple studies have been suggested that MIS restores stability, alignment while achieving return to the function quite early as compared to conventional open TP fixation. Percutaneous screw fixation is a novel technique, and for such technique, a surgeon should have good fine surgical skill as well as good thoracolumbar landmark, especially under the fluoroscopic guidance, which is very important for the accurate placement of the percutaneous screw into the pedicles. Here you can see the slides, AP view and lateral view. This is the pedicle. And under fluoroscopic guidance, the trajectory is made in such a way that medial wall of pedicle should not breach, so the canal cannot be compromised. Claimed disadvantage that there is steady learning curve, inability to visualize the proper anatomy, and difficulty of implant distraction. The rationale of our study is to determine the outcomes of minimally invasive spine surgery, especially in terms of post-operative pain and mean hospital stay. And for that, we did our descriptive case studies in which we selected 90 patients who fall into the category of, in the span of 4 years from July 19 to June 23, out of which my 90 patients, 69 were male and female are 21. This is our operation definition. For assessment of pain, we use a Dennis pain scale. It has 1 to 5 score, which is described in later upcoming slides. This is our setup CM operational step. After taking informed consent, patient placed in a prone position, and after identification from the landmark under fluoroscopic guidance, we insert a Jamshidi needle, and with each advancing movement of Jamshidi needle, we confirm our trajectory so that medial wall of pedicle should not breach, so that canal cannot be compromised. After that, we insert the K wire, then screw bonded to the screw lengthener by drilling above the K wire placed under pedicles. Pedicle screw with diameter of mostly 5.6 to 6.5 millimeter are used, and length of 30 to 50 millimeter are used. The slopes of the rod were immobilized, and the accuracy of implants were checked under the fluoroscopy guidance. Wound color is done in musculofacial layer, subcutaneous, and scale layer. This is our operation team. This is the email about the post-op X-ray results. Out of 90 patients, 42 patients will fall in age group of 18 to 40 years of age. 48 will fall in the age group of 41 to 60 years of age. 69 were males and 20 were females. This is a Dennis pain scale. As I already mentioned, there's 5 scores, 1 to 5. 1 is no pain. 2 score minimal pain without use of medication. 3 moderate pain with occasional use of medication. 4 is moderate to severe pain. And 5 is severe pain with chronic use of medication. So out of 90 patients, 76 patients were placed in score 1, which have minimal no pain. And 10 patients were placed in score 2, which have minimal pain without use of medication. And 4 patients were placed in score 3. A study has been done in Egypt for the outcomes of percutaneous pedicle screw fixation. One of the outcomes were post-operative pain. For that, they used visual analog score. So you can see how this technique has good outcomes, especially in case of post-operative pain. Our mean hospital stay was 2 to 3 days, sorry. Let's start with the discussion. Initially, percutaneous screw fixation was started in 1970, and it was used for temporary external fixation. But with recent advancement in such technique, this is now used for internal fixation, and it is multiple studies have been suggested that percutaneous screw fixation has significant advantage over traditional approaches because there is less tissue dissection, less muscle dissection, decreased operation, decreased blood loss, shorter duration of operation. All these lead to shorter hospital stay as well as reduced pain. Many studies have suggested that as compared with conventional open TP fixation, it is found that post-operative pain, blood loss, and mean hospital stay were found to be significantly reduced associated with MIS transpedicle fixation. As I already mentioned, there is less traumatic approach, less tissue dissection, less muscle retraction, decreased bleeding, short duration of hospital, and good cost-benefit results. Drawbacks of this, there is increased use of fluoroscopy guidance in such techniques, so the radiation exposure in MIS is comparatively higher as compared to the conventional open TP fixation. And the steady learning curve, a study has been suggested in 2014, which showed that at least 20 to 30 cases were required to overcome this learning curve barrier. Bony fin is difficult to be done in such technique. Conclusion. We concluded that MIS has better outcome in terms of post-operative pain and mean hospital stay as compared to open TP fixation. Also, we concluded MIS associated with decreased bleeding and shorter duration of operation as well as good cost-benefit results. So on the left side of my picture, there is a conventional open TP wound, and on the right side, you can see how beautifully wound is closed in MIS. So this is the beauty of this technique, good cost-benefit result, which lead to a satisfactory outcome of the patients. This is our respective department, Neurosurgery Unit 2, under supervision of Professor Dr. Shahzad Hussain Shah. Thank you very much, sir. Thank you.
इससे नहीं हो जाएगा, इससे भी हो जाएगा, इसमें आप बोल रहे हैं इससे पीछे Assalamu alaikum. I am Dr. Shabia Aisha, resident of neurosurgery at Dow University of Health Sciences, Karachi. I will be presenting on behalf of Dr. Sudha Chokat. ये कौन सी है? एक मिनट. ये वाली नहीं थी, इसमें आप मैंने 3 फोल्डर था जिसमें 3 प्रेजेंटेशंस थी. जी जी. Dr. Shabia Aisha. Okay. The topic of my presentation is normative score and cutoff value of spasticity disability index in patients who present with lower back pain with and without disability in Pakistani population. This is the institute I work in. Spasticity disability index is a scale which is used to measure disability caused by lower back pain. It consists of a questionnaire of 10 questions which are related to activities of daily living. We have further subclassified the ODI score into 5 subtypes, with ODI score of 0 to 20 showing minimal disability, 21 to 40 showing moderate disability, 41 to showing severe disability, 61 to 80 crippled patients who are unable to do daily activities, and 81 to 100 who are bedbound. This is the ODI score Urdu version we use in our study. The objective of my study was to determine the normative score of ODI in patients who didn't have lower back pain, as well as to measure the cutoff value of lower back pain patients with and without disability in Pakistani population. For the definition of lower back pain we used in our study was pain localized between the costal margin and the inferior gluteal fold with and without lower extremity pain in the last 4 weeks. And the definition of lower back pain with disability we used in our study was the ability to not engage in activities of daily living for more than 1 day due to lower back pain. It was a cross-sectional prospective study done over a period of 5 months from April 2023 to August 2023 in our setup. The inclusion criteria included all the patients over the age of 18 years who presented to us in ER or OPD with lower back pain and the attendants who were accompanying those patients. The exclusion criteria included the patient who presented with tumor, trauma, or any other deformity unrelated to degenerative diseases, or the patient who had pain due to any other condition like fever, cancer, menstruation, etc. The result of my study was the mean normative score in normal population was estimated to be 4.62 plus minus 5.65 standard deviation, whereas an individual who were experiencing lower back pain had a mean score of 37.48. Among the patients who had lower back pain, in patients who have disability, the mean score was 66.9 plus minus 14.68 standard deviation, whereas in patients who didn't have any disability, the score was 30.0 plus minus 23.6 standard deviation. This is a bar graph which shows age frequencies in our study. This is a pie chart which shows comorbidities in the patient who were enrolled in our study. Most of the patients had no comorbidities, but among the patients who had comorbidities, hypertension was the most prevalent one, followed by diabetes. Among the occupations, most of the patients we enrolled were homemakers, that is, they were housewives, and followed by desk job workers and laborers. This is a graph which shows the relation of ODI score with age in male and female gender. It can be seen that with the increasing age, the ODI score was estimated to increase in both of the genders. This is again a graph which shows the relation of ODI score with occupation in both female and male genders. In females, the most common two occupations were either housewives or students. In housewives, the ODI score was seen to be on a higher side, whereas in student it was on the lower side. Among males, the most prevalent occupations were laborer and desk job workers, and among them, laborers had higher ODI score and desk job workers had lower ODI score. This is a bar chart which shows the overall occupation and their association with ODI score. The highest ODI score was estimated in housewives and in laborers, whereas in desk job workers and students, the ODI score was comparatively lower. The purpose of my study was to estimate the normative score and cutoff value in our Pakistani population. It was based on a parent article mentioned below, which shows which was a nationwide survey done in Japan to estimate the normative score and cutoff value in Japanese population. In their study, the normative score was estimated to be 8.63, whereas in our study, it was 4.63. In their study, the normative score, the ODI score of patient without disability was found to be 11.88, whereas in our study, it was 30.0. In patient with disability, the ODI score in their study was 22.7, whereas in our study, it was 66.98. This signifies the demographic and geographic changes in the score with different population, and it can be deduced that a larger study on a larger scale involving multiple centers would be of great benefit for future correspondence. The limitation of my study was it was a single center study, and the sample size was small. So it can be concluded that the finding of this study provide a valuable insight on the normative score and the cutoff value for ODIs for lower back pain in Pakistani population, but a larger multi-center prospective study would be of more benefit to validate these outcomes. Thank you.
Thank you. The next speaker is
USB lens.
Dr. Sana Jamal. She's from Jinnah Hospital. She will present about the outcome of spinal dysplasia surgery without electrophysiological monitoring in the source constrained country for 10 years institutional experience.
हाँ सही सेशन कौन सा कॉपी करके रखो फिर मैं सर सॉरी कर दी कौन सी आउटकम
ये आउटकम स्पाइनल डिस्प्लेसिया अच्छा पॉइंटर नहीं ऑन होता ओके अस्सलाम वालेकुम एवरीवन आई एम डॉक्टर सना जमाल पीजीआर न्यूरोसर्जरी अल्लामा इकबाल मेडिकल कॉलेज जिन्ना हॉस्पिटल लाहौर टुडे आई एम प्रेजेंटिंग आवर स्टडी on spinal dysraphism under supervision of Professor Fozia Sajjar. Today, neurophysiological monitoring has become an essential tool for the surgical management of spinal dysraphism. The aim of our study is to highlight the fact that it can be possible to achieve the aim of our study is to highlight the fact that it is still very much possible to achieve these results. Results of these surgeries done without the help of neurophysiological monitoring. As we all know that spinal dysraphism is a congenital anomaly resulting from an incomplete aberrant neural tube fusion. There are two broad categories of spinal dysraphism, spina bifida aperta and the spina bifida occulta. Spina bifida aperta is a very manifest anomaly, and these patients are quickly recognized because of it. These can be myelomeningocele. This can be meningocele, myelomeningocele or myeloschisis. Diagnostic problems are encountered when the defect is either not manifest, and spina bifida occulta may be lipomyelomeningocele, dermal sinus lipoma, tethered cord, and split cord malformation. The incidence of the disease, is 1 to 3 per 1,000 live births, and it is more prevalent in female child. In Pakistan, the disease is more prevalent in the southern Punjab and the northern areas. The folic acid deficiency is the major contributing factor
playing an important role in this congenital anomaly. The patient with spinal dysraphism presented with 3 broad categories of clinical features. These may be neurological, orthopedic, and urological. The mainstay of treatment of spinal dysraphism is surgery, and the time of surgery is very important. There are centers in the world which are doing intrauterine repair of the spinal dysraphism, and the surgery of the spinal dysraphism should be done as early as possible. In the cases of leaking meningocele or myelomeningocele, the repair should be done within 36 hours to prevent infection. There are different surgical techniques which are used for spinal dysraphism surgery, but the few techniques, they are common in all types of the spinal dysraphism surgery, such as pre-planned skin incisions, laminectomy, exposure of the normal dura, identification of the neural tissue, unteething of cord, watertight dural closure, and the skin closure. The main issue arises during the identification of the normal neural tissue and the phylum terminal. Neurophysiological monitoring is used to help the identification of the phylum terminal and the nerve tissue, but with the good surgical skills, you can identify the phylum terminal and the nervous tissue on the basis of their neuroanatomy. The nerve roots, they are pearly white, while the phylum terminal is yellowish in color, yellowish white, and the coarse in consistency. The nerve roots, they are going laterally and exiting through the nerve root foramina, while the phylum terminal is central in position. There is serpentine blood vessel runs parallel to it, and lower down it is caudally attached to the dura. So this is the thickened phylum terminal. These are the nerve roots which are going laterally. Neurophysiological, there are different techniques which are used for neurophysiological monitoring. These are somatosensory evoked potentials, electromyography, motor evoked potential, combined muscle action potential, and the bulbocavernous reflexes. The phylum terminal and the nerve roots, they are identified through neurophysiological monitoring on the basis of the difference in threshold, which is 100:1. The 0.5 to 2 milliampere current generates a stimulus in the nervous tissue, while the 10 milliampere current, if the non-nerve stimulus is produced using the 10 milliampere current, then it is extraneural tissue. So we analyzed 200 patients in our department over a period of the last 10 years. And we compared compared the outcome of the results at the 2 years follow-up. This is the gender distribution. In our study, there were 70% female patients. So we encountered the almost a whole spectrum of the spinal dysraphism, in which there were 80% of the meningocele patient with, out of which 20 patients they had hydrocephalus. We encountered 4.8% of patients with split cord malformation, 8% patient with thickened phylum terminal. The mostly patient presented with swelling, that was 52%, and the patient with bladder and the bowel symptom, they were 14%. Mostly patient, they had lumbosacral spinal dysraphism, and we encountered only one patient, that was 0.5%, that had cervical spinal dysraphism. So these are the few surgical cases. This is a case of the meningocele. The dural margins were identified and the dura was tightly closed. This is a case of myelomeningocele. Continuing the dissection of the myelomeningocele, the neural tissue was identified, the normal dura was identified, and it was then tightly closed. This is the case of lipomyelomeningocele. The pre-op picture of the patient showing the hypertrichosis. The conus was low-lying. This was the lipoma. The conus was ending at L4, L5. These were the intraoperative picture of the patient where the neural the cord was untethered and then the dural margins was tightly closed. Another case of lipomyelomeningocele, MR pictures showing lipoma and the neural tissue was protruding out of the defect. These were the intraoperative picture. The lipoma was shaved off. So these were the cases. This is another case of the patient with diastematomyelia. The overall outcome of the patients, the outcome of the patients, there were 76 patients which remained static, and 17% they have improved neurology after 2 years follow-up. 7% patients were deteriorated. So these are the bladder and the bowel symptoms improved in 64% of patients and deteriorated in 10% of the patient. So our results were comparable with an international study done in California, in which the neurophysiological monitoring was used during surgery of spinal dysraphism. In our study, 64 patients with bladder and the bowel symptoms were improved in comparison with the 60% patient in Alfredo et al. 8% patients were deteriorated in our cases with back pain, and in comparison with 12.5% patient in the study. So the take-home message was, although these modern gadgets, they are helpful for the surgery and they should be used, but in a developing country like Pakistan, where these expensive tools, they are not available in every setup. So our residents should be trained enough to do these surgery with successful results. So basically, it's the surgeon and the surgeon's oxides which are behind these successful surgeries. Thank you.
गॉर्डन का हुआ है, ऑनलाइन है, हाँ है ना, दूसरों को भी ले लें। अनाउंस कौन करेगा? आपका
जोशो भाई मैंने कर दिया। जोशो भाई मैंने
We are having a short of time, that's why we have just recited 2 papers, maybe 2 or 3, but we have to start the state of our lectures because most of the international faculty was invited because of the Middle East situation, they didn't came, so we have to take them online. And our first state of our lecture Dr. Gordon, can you hear us? Is there any mic on the Dr. Gordon? Open. Audio, please. कहाँ हैं आप? वाले जी. क्या देगा? हाँ मेरा नंबर भी कॉल. ठीक ठीक ओके.
Hello, sir. Can you hear me? Yes. Wait. Hello. Wait, sir. Can you test the sound for speakers? आ रही मैंने देखो आ रही सर हाँ हेलो सर कैन यू हेयर मी यस
Hello? I can hear you, but you need to be closer because otherwise I will not hear you to the microphone. Thank you. Okay, I will, thank you for inviting me for a presentation. I will try to give you, I know, I'm sorry I couldn't come to the Pakistan because my issue with the visa and my passport, it was an unfortunate event. But I would like to talk to you about the enhanced recovery after spinal surgery. Well, if you don't know who am I, I'm actually Gordon Grafowitz from King's College Hospital in London. I've been working in London for the last 8 years. And enhanced recovery after spinal surgery is becoming extremely popular now after the COVID. Why? What is the problem? I'll try to give you a couple of answers during my talk. So what is the ERAS? ERAS, as you can see, this is a complex, it's actually evidence-based medicine, which is focusing on a preoperative care to improve the outcomes of the patients in the numerous surgical areas. Or how this is achieved? It's achieved through the multimodal optimizations of the patients, patient pathways, reduction of the complications, and at the end to improve the patient's experience. That will lead to also to the shortening of the length of the stay. It was first described in 1997, so a long time ago, as you can see, but it's becoming more popular in the last, I would say, decade, especially in the neurosurgery or the spine surgery, with some areas more recently maybe going toward the neurosurgery or any other areas of our neurosurgical field. Well, initially it has been called fast-track surgery because it has been developed by the orthopedic surgeon, but interestingly, it has been first implemented in colorectal surgery. ERA Society, which always comes when something is good and it's well been presented on the, I would say, established in the field, it has been actually come in 2010. So you can see almost 13 years with the delay. Well, where this all originates from, if you know what is the Toyota production system, and you can see this is a standardized system which has been developed by Toyota from 48 to the 75. So almost 30 years it took them to figure it out how to make it a more efficient car manufacturing. And what is the primary goal? So as you can see, they have 8 goals. Always is a reduction of the waste. Why the reduction of the waste? Because that increases the productivity and it decreases the income. And in the Toyota production system, there are only four major parts: before, in, out, and then you deliver the car to the happy customer with the reduction of the total cost. Well, that's what something similar the ERAS wants to achieve. So primary goals of the ERAS is to shorten the length of stay. Hospitals are quite keen to. Decrease the cost of the hospital or healthcare system. This is becoming extremely important because we are all limited with the number of our money in our systems. And we want to reduce the post-operative complications and readmissions because that will offload the beds and actually at the end improve the patient experience in totally. So the main objective is to improve the patient recovery and putting the patient under the spotlight and the center of the whole journey, and also empowering the patient and that they need to accept the responsibility in their own recovery plan. So the patients are a crucial part and the members of the whole journey. So the components of the ERAS, any medical ERAS, surgical ERAS, is that they are composed of the preoperative, intraoperative, and postoperative part, as you can see here. And they can vary from the hospital to hospital, from the service from the different speciality, because it can be adjusted according to the difference of specialities. Well, what is in the ERAS in the complex spine surgery? As you can see, preoperative education and counseling is on the top. So the patient is in the center of everything. Then we have a preoperative, which goes through the preoperative, intraoperative, and postoperative phase. As you can see on the postoperative part, the day of the discharge can be the day 0 all the way down to the day 3. In vast majority of the cases, we talk about the lumbar fusion, so you can actually match if you have achieved successful journey of the patient in the ERAS, or if it's necessary a little bit more. Preoperatively, and it's always the major components, it's everything is audit, review, comply, and adjust the new parts of the ERAS pathway at every point. I will try to go slowly through the pre, intra, and postoperative part. You can see that some parts are going from pre to the post. Some are completely located to the, I would say, certain parts like intraoperative parts, and some are like only considered just for the postoperative part. So preoperative recommendations. What does it mean, preoperative recommendations in the counseling and the education of the patient? Because the patient is the cornerstone of this pathway. Well, current ERAS protocol will all emphasize that the patient is quite important to educate the patients and counsel them very well during the elective spinal operation. But what is interesting within the spinal literature, there's actually limited evidence of preoperative education and counseling that will have any kind of meaningful reduction, meaningful impact on the length of stay or reduce the postoperative pain. So we can talk, but actually the evidence is quite low with the patients, but the recommendation is extremely strong. Why? Because the patient needs to know what is the expectations. We will do some things which will probably not have meaningful impact on the length of stay, so much desire, but the patients be aware of any kind of ups and downs, what can be in their journey, to better understand the journey, expectations of the surgery, counseling them, consenting them, which is quite important, becoming more and more, that we give them the cooling off period before the surgery so they fully understood all the risks and benefits of the surgery. So pre-rehabilitation, it's extremely important, especially in the hips and knees, but which usually requires combinations of exercise, nutrition therapy, psychological preparation, but in the clinical literature, there is insufficient evidence, body evidence or that the pre-rehabilitation will improve functional outcome after spinal surgery, so it cannot be recommended or any kind of conclusion can be made. Nutrition supplements. Well, there was a lot of talk about combinations of how we actually assess that if somebody is malnourished. Well, there's a plethora of lumbar testing, anthropometric measurements, or any kind of standard assessment tools, all to help us to assess how the patients are, if the patient has any kind of problem with the malnourishment. We know that the low albumin, low transferrin, low lymphocyte counts, they all behaving associated with the actually increased risk of surgical site infections, increased postoperative complications, increased length of stay, 30 days of admission, even increased mortality following the spinal surgery. But what is crucial, where if we modify any of these factors, the body of the evidence of the current literature doesn't tell you that the preoperative nutritional status will result in improved clinical outcomes following the spinal surgery, and that can't be confirmed. There are some papers that are talking about maybe it will have the impact on the patient's bone effusions, but there are only sparse and there are only few papers on the literature. So the evidence is low, but knowing that because of the connection of positive connection of low albumin and low transferrin, the recommendation will be quite strong that we need to optimize our patients before the operation, or at least to try to indirectly reduce the possible risk of surgical site infection or any kind of other postoperative complications. Smoking. Smoking is the disease of the modern age, and we all know that the tobacco smoking will cause lots of problems, especially from the pulmonary cardiovascular complications immediately after operation. Will be troubling also the long-term cause of the lumbar fusion, and at the end it will get worse functional outcomes. Deep vein thrombosis, morbidity and mortality is also included. So the recommendation, and there's a good strong body, I would say, good quality of evidence which will tell, and the recommendation is quite strong, that we should encourage the patient to reduce the smoking at least 4 weeks before the operations. Recommendations between the institutions usually varies between 4 to 6 weeks. So stopping the smoking before significantly reduce the pulmonary risks if the patient stops smoking at least 4 weeks beforehand. Cessations of drinking, big problem in the UK. People drink even more after the COVID, but the drinking brings the other risks. As you can see, only daily consumptions of more than 2 units of alcohol will increase the risk of postoperative complications. They're pretty much similar, like lumbar, like with the smoking, but here it's more common: delirium, bleeding episodes, and postoperative ELOs, which is quite specific for alcoholism. Alcohol cessation program, well, includes a little bit longer cessation, at least to 4 to 8 weeks, to try to reduce the complications after the operations. And also, if you have a consultant liaison person in the hospital, which will be preemptively be warned when the patients with alcoholism are admitted, so they can start also pre and post-operative drug administrations and keep them under close surveillance, because it's not nice if you go for a spinal operation and you end in the ELOs or delirium. The results and the length of stay and the results for that patient will be, or journey for that patient will be much worse, and the length of stay will be much longer, and that's not our aim. Fasting and carbohydrate treatment. Well, if you ask any surgeon, will tell you that at least you should stop eating and drinking 6 hours before general anesthetics. And the whole reason is to reduce the gastric volume and acidity in the stomach, to try to reduce the risk of pulmonary aspiration. Well, European Society of Anesthesiology has new guidelines which have changed during the, I would say, my clinical area, that now you can drink all the way up to the 2 hours, and light solid meals may be ingested 6 hours before the surgery. So water, coffee, black coffee with no milk, you can drink up to the 2 hours before the surgery, and it's recommended that actually you drink and you're not dehydrated before you go to the table. So that's quite important to keep in the mind when if this is not implemented, because it has a good outcome on the patient performance after the surgery. We know that every trauma is like any surgery is a traumatic event for the patient, and that would put them in a catabolic state because of the most neuroendocrine response. And that increases as you know, if you're in a catabolic state, you have a protein breakdown, you have a post-operative hypoglycemia, and that can also have an effect on the outcome of the surgery. You're in the shock, and that's the reason we always tell the patients it will take some time to recover after the surgery. Well, carbohydrate loading, well, it's one of the reasons how you can mitigate that. This will not that will reduce the risk of happening. Yes? Can you hear me? I will continue if you can hear me. So the preoperative carbohydrate loading with the stopping of the drink at least 2 hours before the surgery it's crucial. It also reduces the risk of kidney injury as well. So there's a good quality of evidence, and it's a strong recommendations to implement this in your clinical practice. Anemia management, it's well known that anemia will affect 1/3 of our patients because we usually operate elderly populations, and that's also increased if somebody's anemic, increased risk of transfusion, length of stay, infection, morbidity, and readmission rate. So there is actually the target that the hemoglobin should be around 30, despite the male or female. Sorry? I was okay. So there's even though it's a low preoperative, the patient needs to be optimized. It's a strong suggestion that the patient should be optimized, because if you have a higher hemoglobin before the operation, it's a better outcome. The patient will definitely lose the blood during the operation. So it's always better to try to avoid the transfusion, because the transfusion brings the certain risk. Pre-anesthetic medications, well, there's many things, but I'll touch just briefly because this is extremely complex. It's about preoperative, a part of the preoperative sparing analgesia. That's the administrations of Tylenol or non-steroids to try to decrease the post-operative pain scores, because there is a huge variability. There is in the different schools of the thoughts, or I would say presentations. There's a good, stronger recommendation that opioid-sparing analgesia should be the mainstream, and that's where it comes preoperative anesthetics. Regarding the anxiety, we would say there's a low evidence of using of anxiolytic drugs to reduce the risk of neurocognitive impairment and the postoperative adverse effects. So it will not be recommended to regularly administer them before the surgery. Intraoperative recommendations, well, antimicrobial prophylaxis, decolonization of the patients. Everybody's using that for many years because we want to reduce the infection of Staph aureus as a main cause of the surgical site infections. And that's quite commonly prescribed everywhere. There is no universal accepted guidelines which antibiotics or antiseptic prophylaxis is the recommended as a gold standard. We all know that 30 minutes before the skin incisions and the redosing every 4 hours during the longer surgery, or if the blood loss is more than 1.5 liters. Well, there's a good body of the evidence and strong recommendations. And the use of chlorhexidine of iodine, there's always the debate. There's papers which will show there's a little bit, maybe chlorhexidine will be much more effective than the iodine, but that may be a slightly statistical error when you look to read the papers or establishing how the papers can be published. Standard anesthetic protocol. Every hospital should have a standard modern general anesthesia and should follow local policies. In preventing intraoperative hypothermia, it will be something which is quite must. There's a good quality evidence of the papers that will show strong recommendations that we should maintain normothermia and avoid hypothermia in our patients, because that's increased with the increased blood loss, cardiac abnormalities, surgical site infections, and increased length of stay. Local or regional anesthetic techniques, well, there's many different papers that have been published about intrathecal, epidural, regional blocks, wound infiltrations. Well, I will tell you that intrathecal, there's a good quality of evidence and recommendation is strong. If there's a practice of your department, then or a certain protocol that can reduce the postoperative pain. Epidural analgesia as well. Local regional blocks are becoming more popular because because epidural or intradural bring certain risks of the procedure or postoperative complications. So the TAP block or rectal spinal block, they're becoming more and more popular because they have shown with less risk profile, they will reduce the postoperative pain in the 70 to 80% of the patients, and with quite a low morbidity profile. Wound infiltrations, everybody uses the local wound infiltration because at the beginning when you make a skin cut, it reduces the immediate response on of the pain. Intraoperative recommendations, there's this is more for anesthesia, it's preoperative fluid management. Actually, it should be that the patients are maintained euvolemic, that it should be a goal-directed fluid management to some extent, but what is quite important is that early postoperative oral nutrition, because the patients are happy when they start eating immediately after the operations, and the normal diet should be prompted and restarted immediately after operation if the patient doesn't have any kind of other problems like postoperative nausea. Urinary drainage, well, there is no good body of the evidence that will recommend for simple lumbar operations or 1 or 2 lumbar fusions that urinary drainage should be recommended. And if it's used, it should be removed within 1 hour after the operation, because that has been increased with the increased length of stay if it stays longer. Intraoperative recommendation surgical techniques. Thankfully, you're now on the conference. You want to discuss which surgical intervention is better. Is it open or MIS? Is it anterior, posterior? Is it posterolateral, etc.? There are too many variations. And this is not the part of the ERAS. So the surgical type of the operations, it's not the part, it can be confounding factor, but it should be left to be discussed on case-to-case basis, because the factoring this into the calculations when you make a meaningful import is much more problematic. Postoperative, well, prophylaxis against thromboembolisms. I think everybody of you are using the Clexane after the operation, even though there is no good randomized studies which will tell you which one is the best after spinal operations and what the duration, what type of the spinal operations as well. Recently, has been published a paper that even the aspirin, if you administer it as a part of chemical prophylaxis, it actually has this almost similar effect as lower weight molecular heparin. Well, using of the drains. Well, as you can see, this is MIS, and you can see frequently on the LinkedIn, etc. People are showing how you've been doing this MIS, and people have a lumbar drain. Well, there's no actually recommendations for any kind of single level or short lumbar fusions if it's a good hemostasis achieved, that the lumbar drain brings any meaningful improvement of the patients. And then the patient will, if the patients have a drain, that will delay to their ambulations and will associate with more pain on the sides, and possible if it stays longer than 48 hours with increased infection. Analgesia, as you can see, analgesia is quite complex. It's a part of the preoperative, intraoperative, and postoperative, and every hospital should have their own pathway, etc. But the primary aim, we want to reduce the opioid consumption, because if the patients are opioid naive and receive the opioids during the spinal surgeries, up to 1/3 can become opioid dependent at the end of 1 year. So it's quite important that you have an opioid scale or World Health Organization's escalation of the scale, how we're going to treat the pain based on the pain score. Postoperative nausea and vomiting, also it's quite important preoperative and postoperatively, because it should be used the multimodal regime to try to reduce it, because that's quite important in how the patient's experiencing after the surgery will become. And how to implement. Well, successful implementation, it's a multidisciplinary concept. You will need to have every member of the party who is enjoyed in the patient's journey need to be around. That's how we established this at the King's College Hospital. And you need to discuss every single bit. You will not be able to start everything immediately. And I would suggest it's to start step by step. The things that you can change from the surgical intraoperative, then talk about the preoperative part, step-by-step implementations, and then the patients, and then you will show the reduction of the variations, the reflection. You can reflect on those variations, etc. And you can then implement and change the part of the protocols, because analysis and auditing, always your results is the best, because the patients, at the end, we all want the patients come in and come out with less complications and regularly, and have a better outcome for us as a surgeon. So, but the question remains, should you develop the different eras for anterior cervical, posterior cervical, because we all know it's a little bit different. Anterior, or like would say, reconstructive surgeries in the lumbar spine for day cases, for metastatic spinal disease. And if you look for the neurosurgery, how we should make the ERAS also for all neurosurgical patients. It doesn't need to be only for the spine patients, etc. And how to do it, like we know, if you want to develop the day cases for brain biopsies, or treating the patients with transphenoidals, it's quite important. And you will be surprised after implementations on the spine ERAS parts. People were quite keen to implement bits and bobs from the spine ERAS into the cranial, such as carbohydrate loading, early nutrition, stop drinking only 2 hours before the operations. Spine ERAS are also existing on the national basis, and that's where the GIRFT comes. As you can see, this is a pathway which is composed of 7 pillars, which tells you how the journey should look like from the national pathway. There's also trying of the, I said, as you can see, this is a day case for lumbar discectomy, how the patient should go to the journey. It gives you the rough outcomes. And what is quite important, it's quite important that you can measure the patient satisfaction, which is extremely important. And you can see that the vast majority, even if you change to the day case lumbar discectomies, to the non-day case, the satisfaction is the same. So the patients which are in the, I would say, in the center of this journey are always happy. No matter if you change, we always need to treat our anxiety, or I would say reluctance to change something, but we need to see how the patients are experiencing any change we made in their journey. So this is actually a rough data that you can see in the 15 months. Now it's more than 2 years. This is only P3 and P4. As you can see, I'm just looking how many patients we have received, what was the median age, which is actually 60 years of age, how we admit the patients based on admissions on the day, or admitted the day before implementations of the ERAS. Vast majority of the patients be admitted the day before. And then we will look to our expectations. What is the length of stay? 70% we achieve the length of stay on the unexpected time frame. And when you have extended length of stay, there are different reasons. And that different reasons will tell you where you need to work and tailor your ERAS pathway. Is this postoperative complications? Is this going on increasing based on the monthly basis? Are we operating more patients on the weekends? Do the patient have a problem with the continence? Do we have a wound infections problems? And what type of the postoperative complications? Vast majority will not have any kind of complications. And you can see the length of stay actually correlates with the complication rate. And actually the extended length of stay pretty much correlates with the postoperative pain levels. So that tells you where you need to put the majority of your force and focus, how you need to change certain parts of your spinal protocol. And hopefully I have managed to finish at almost in the nick of time. Thank you very much.
The mic is over to Professor Juma. It's okay? Yeah. Thank you so much, sir. So the next topic is of our international speaker, Professor Mehmet Zaleli. And for that, I would like to request Chairperson Professor Tariq Salahuddin Saab to chair the session. And the secretary will be Professor Shams Raza Broi. So Professor Shams Raza Broi, kindly come on the stage and accompany Professor Tariq Salahuddin Saab.
Welcome, Mehmet. Professor Mehmet Zaleli from Turkey. He's, I think he doesn't need any introduction in Pakistan. I think soon we should be giving him the nationality of Pakistan because he's here so often. And he has a special interest in spine and is recognized all over for his expertise. So listen to his talk today. What are the common complications that one does in his
spine surgery and how to rectify them. Professor Mehmet Zaleli.
Dear chairpersons, dear friends, yeah, I feel like I'm a Pakistani. I'm here for many, many years, probably more than 20 years. I'm visiting Pakistan, and I have many friends with you. This time I will make a different talk. What are the mistakes in spine surgery? And then I will try to outline some common mistakes and which we must avoid. It is not working this way? Yeah. Good. First of all, complication and mistakes cannot be differentiated from each other very well. From the perspective of the patients, one of the complications may be considered as a mistake. And avoidable complications may be considered as a mistake. If it is not avoidable, it's something else. From that paper from 2016, for instance, making a wrong level surgery is considered as a mistake. However, after surgery for disc herniation, leg numbness, donor side pain are complications. However, disc herniation, somebody says it is a mistake, but somebody says it is an inevitable incidence that you cannot avoid it. So this is my simple classification for general mistakes in spine surgery. If we know them well, we can avoid them. Mistakes of indication are the most common ones. I will show you a case. This is a 74-year-old female patient who had a previous lumbar disc surgery at L5-S1 level. And she described later a new onset sciatic pain after a while, 1.5 years later. Then the surgeon has seen these films, and probably you would give some gabapentin or pregabalin, or you'll advise some other measures, but you would never do a fixation surgery like this. So I consider this as a mistake. Why do we have such problems? First of all, spinal disorders do not come to you as I have a lumbar spinal stenosis. I have a back pain or leg pain. So most of them are non-specific. And the source of pain is not easily identifiable. This is the main reason of indications problem. And only 10 to 15% are really specific diseases. One reason is that evaluation of the pain is not easy. There is a worse correlation between the pain and radiology. You can have a person with severe stenosis, but no neurological claudication. What would you do? Just leave the patient there. Don't touch that patient. Pain is polluted by many factors: psychology, social, environmental, some beliefs even. They are really affecting the pain. And patient selection is more difficult in spine surgery than cranial surgery. Although this meeting also is dealing with the from open surgery to minimally invasive, yes, we try to apply it. I also do myself. But in fact, most of the mistakes are not from the surgical techniques. They are from patient selection. And we do most failures because selection of wrong patient. This is another case. This patient has been recommended a 3 levels discectomy, graft and plate surgery. But I examined the patient. She had a thoracic outlet syndrome, and I advised some recommendations and I did not operate. And nothing happened. She got, after a while, she got pain relief. What about this? This patient came to me with a significant free fragment L5S1. But at the time I saw the patient, he had no pain at all, no sciatic pain, just some numbness in the foot, S1 area. Why do you operate? But many of you would think that, yeah, it would be nice for me to remove that part from there. This is like a toy. This is like a fun. However, we know from the literature those free fragments can disappear more often than central protrusions. The free fragments disappear after 3 to 6 months mostly. So the reasons of mistakes of indication are not obeying the rule of operating films, not the patient, and forgetting that spontaneous regression or spontaneous cure happens in most of the degenerative diseases. Improper patient evaluation, because of pain evaluation is quite difficult. Patient psychology, patient's unrealistic expectations, and training programs are focused on surgical techniques, not the patient selection. There may be some corruption, but I cannot interfere with this. I cannot tell this. Somebody may have getting some commission from implant companies. So, what about mistakes of approaches? The most common is the insufficient decompression. This is one case from my department. She had an 80-year-old male, very severe deformity together with spinal canal stenosis and tetraparesis. He had a median corpectomy, but the compression is not enough, and the screws are short. There is no lordotic component of the plate, So there are multiple small mistakes. So we operated him once again and did a good decompression and placed a graft and a more strong plate. What about this? L1-2 disc herniation. This one is operated by a posterior surgery. It was a hard disc herniation, and the surgeon could not remove it. And he left the patient in this position. Then again, an insufficient decompression, an improper approach. If I have known that it is a calcified disc herniation, I would do an anterolateral surgery. I wouldn't do a posterior surgery at L1-2 level because it is conus level and you cannot make it nicely. And you can even cause some deficits. What about this? This surgeon has done a discectomy for an extraforaminal disc herniation, L5-S1 disc herniation. For such a disc herniation, it doesn't show? Yeah, very weak. Yeah. For such a disc herniation, you cannot go from inside the canal. You must go from outside. For it is far lateral. And second, why at the end you place a so-called between cage inside? And he couldn't make it properly, and then the cage is inside the retroperitoneal space, just near to the iliac artery and vein. So, improper technique and a mistake. What are the reasons of mistakes of approach? I approach that case I am familiar with. Even if it is far lateral, I do posterolateral approach. Even if it is anterior, I do a posterior surgery. Why? If you make it, then you call new mistakes and new problems. And sometimes the sentence is used, my aim is implant placement, not decompression. I see many cage insertion, especially in cervical spine, without improper decompression, without proper decompression. What about stabilization? Most of the mistakes of stabilization is from the lack of knowledge of biomechanics. And we must learn them very, very well. Actually, probably in our basic training programs, biomechanical information is lacking. This patient had screw breakage because anterior support is lacking. And it is in the thoracolumbar junction, junctional areas, we need more fixation points. We did a revision surgery with extension of the fixation. What about this? This patient had a rod breakage after a while. Both rods are broken. Why? Because the first surgery has skipped 2 levels to include the 2 levels above the fracture site. This is again trauma. We revise it. Another great mistake is that, especially for neurosurgeons, they do not prepare a good graft bed. You must, actually, if you are trying to make a posterolateral fusion, you must strip all the muscles from there on the facet joints and transverse processes, and then place a handful of grafts. If you don't do it, the non-union will happen, and the patient will become more painful after a while. Insufficient graft placement or no graft. Sometimes I see even no graft, nowhere. And since it is a bit extension of the surgery, interbody grafting, cage insertion, and graft placement are also not done mostly. We must know there is such a graft. After approximately one year, the metal fatigue happens. And if you have not provided a fusion, then the implants will get loosened and will fail. This is a very common problem. So implants or screws are used for securing the stability for a period of time only. After 1 year, they are replaced with the fusion mass. If you don't do it, then the patient will become more painful. So this is mostly the incidence. Fixation surgery aiming fusion or dynamic fixation. After a while, pseudoarthrosis happens, instrument failure happens, and screw loosening, screw breakage or rod breakage happens. It's very common. I'm sure you are also seeing some patients like this. How to avoid? We need more training. We need meticulous technique. We need AP and lateral view by C-arm. I see in many centers, AP views are neglected. They do mostly with lateral views only. Navigation and intraoperative CT will help, yes, but they are very costly. Yeah, if you have it, this is nice. What about screw malposition? This may be considered as a complication if you don't have a good navigation system or a good C-arm system. But if you haven't looked with AP, you cannot notice or realize that you are inside the canal. Another mistake is the complication management. If you see that film and the patient has some neurology, you must revise the patient, for sure. If you don't do it, it's another mistake. Yes. What is important? Neurologic deficits, vascular injury, biomechanical strength of the screw. We see many such things. And instrument failure is mostly because of insufficient grafting. And I must stress again, this is the most important stage of the surgery. However, especially neurospine surgeons neglect that part of the surgery. They get tired. By placing the screws, they think they have finished the surgery. No. They have started surgery making fusion after placing screws. Mistakes of construction design. There are many such things, especially in deformity surgery. Stopping at the junctions, stopping at the apex of kyphosis or scoliosis, overlooking the lumbar lordosis, not trying to restore the lordosis, long fixations, overlooking the sagittal balance, this is also very important, and lack of anterior support. These are very common mistakes, especially for long fixations or deformity surgery. I will show you some examples. This is a typical proximal junctional kyphosis because the surgeon has stopped at the junction, thoracolumbar junction. Another one, this patient has been operated by stopping at the apex of scoliosis. This is a mistake. you must cross it. Otherwise, the patient will have more pain later, and then a second surgery was necessary to extend the fixation. Long fixations. This is another issue. Sometimes some surgeons believe that by extension, in the primary surgery, by making longer fixations, you are guaranteeing in the future you will not have another problem in the adjacent level. But this is not true. You are having more problems by making long fixations. So this is a very common mistake, especially in degenerative spine, to try to make long fixations. Here, this is a complication of longer fixation. The upper part of the rod is broken, and then there has happened a PJK-like lesion, a screw loosening. Why? Because the patient has very osteoporosis, very severe osteoporosis, and the screw purchase were not good. And the loosening of the screws is a sign of non-union and a failure of fusion. Long fixation, in this series, it said that 460 cases without significant deformity, there was no significant difference if the fusion is done at one level than 2 to 3 levels. So try to make it as short as possible. We need more training and experience, but on the other hand, I must say the experienced surgeon is the surgeon who has done many mistakes in the past and who has learned from their mistakes. If not, it's silly. Mistakes of complication management, I will give some examples, especially CSF fistula. If you don't behave timely, you can get infection, and then you'll get more problems later. No action in case of implant failure. As I've shown you, malpositioned screws must be replaced, must be tried to operate again. This female patient had a anterior plating with screws, and after a while, the surgeon has seen this film and did not react to that. Okay? But such a screw may penetrate the esophagus. And at this stage, I saw the patient, and that screw was absent, disappeared. It has eroded the esophagus and digested, went out. And I repaired the esophagus during surgery. This is traffic accident 5 months before, and that man had such a film. Probably I did not see the preoperative films, but probably a conservative treatment would be also possible. But the surgeon who has seen this man has operated him, and postoperative left leg pelagic, because one of the screws is in the midline, inside the canal, and injuring especially L2 and L3 roots, I think. And he didn't behave against this. He didn't remove that screw. And he came to me 1 year later or something. I forgot. Yeah, I removed it, but the plagia did not resolve totally. The idea, I have no complications, no need for a revision surgery, new treatments, is absolute. There is not such thing. If you are not operating, you will have no complications. Yes. Yes. This is the best probably. If you are not a surgeon, you have no complications, no mistakes. Some of your complications may be considered as a mistake. This is another thing. In my practice, I have counted some of the mistakes, and I found that most of the mistakes are from indications. Mistakes of approach 10%, mistakes of stabilization 20%, and complication management is about 10%. So this is my general philosophy, how to behave against mistakes. One important thing is the lack of knowledge, insufficient training, because of wrong indications, unnecessary instrumentation, and lack of biomechanical concepts. I must stress those. Surgery without sufficient technical conditions may be another mistake. If you don't have a C-arm intraoperatively, you must not make a spine surgery, at least no spine surgery. Accepting new techniques implants without consideration of evidence. For instance, I can tell you many implants who are now in the history of spine surgery who nobody uses. Like I said during the cadaver course, Halifax clamps are not used anymore. There are many such things. Lack of experience, lack of learning from mistakes are the main reasons. And we probably must warn surgeons thinking instrumentation is fun or creating corruption with implant placement. Thank you for listening to me. If there are any questions, I can...
Excellent talk, Mehmet, I must say, and I think you have made us wise in areas of wrong indication, treating the x-rays, not the patient. And of course that, you must admit that you have made a mistake. And people who talk that they do not have a mistake, probably they are not operating.
Yeah.
If there are any comments, or I think basically this is state-of-art lectures, so one is not supposed to be asking any questions, but I think Mehmet is very generous. So if anybody would like to ask him any question. Yes, please. Short one and brief. A mic de dein ji inko.
Is there a microphone for questions?
No questions.
No questions? Sorry. Okay.
So it's not a question, I just want to get some guidelines. Like you have emphasized a lot on graft. You need to do a proper amount of graft. How would you say about MIS? When you do percutaneous screw placement and there is no space for such, bony graft placement?
There are techniques to place grafts with MIS techniques, but if you think you will not be able to do that, you must make a open surgery. Yeah, you must not neglect that part of the surgery. This is my idea. Thank you. Thank you.
Thank you so much, Dr. Zilali. We are thankful to you that you joined us in NEUROCON 36. So our next state-of-art lecture is late Dr. Bashir Memorial Lecture. For that, I will call Professor Dr. Asif Bashir and Dr. Qasim Bashir to come on the stage and chair the session. Our speaker is Dr. Bruce Hall, and he's from Australia. He was very much interested to come Hyderabad, Pakistan to attend the NEUROCON, but again, this was unfortunately, he couldn't because the Middle East situation. Hello, Dr. Hall, how are you? Yeah.
One moment. Can you hear us? One moment. We cannot hear you. There is a problem in your voice. Hello, Dr. Hall. Yes, we can hear. We can hear you from the laptop, but we cannot hear you as a speaker from the louds.
Is there something that I
Yes,
can do?
now it's good. So over to the sessions chair, Dr. Asif and Dr. Qasim.
Can you see my presentation? Hello?
Thank you, Professor Bruce Hall. It's a pleasure to have you give this memorial lecture.
Hello, can you see me? Can you hear me?
Yes, can you hear me, Professor Hall?
Should I start my presentation?
Yes, please, go ahead and start. You have to unmute kariye wahan se.
Okay, so you can see my slides and you can see me. All okay? Well, good morning, everybody, and thank you for inviting me to speak this morning. This is a very great honor to give the Professor Dr. Bashir Memorial Lecture. I'd especially like to thank Professor Raja and his organizing committee for this opportunity. I sincerely apologize for not being there with you. A special thank you to Syed bin Innes, our recent fellow at Princess Alexandra Hospital, for introducing me to Professor Raja. And I note that Syed is giving a talk later today on his experiences as a fellow in Australia. I visited Pakistan 25 years ago, and I met Professor Iftikhar Raja. I see that one of his lectures in memoriam for him is on today. I did not meet Professor Bashir. He had sadly passed away. But I do have a link to Professor Bashir. He worked at Newcastle upon Tyne with one of my mentors, Professor Glenn Merry, and he also worked in Edinburgh with Professor Lee Atkinson, another mentor of mine. They both spoke very highly of Professor Bashir, and it's an honour to give his memorial lecture. My topic today is the training for neurosurgeons in Australia. I'm just looking at this, and I was going to talk to you about opportunities for foreign trainees to train and study in Australia. And I am really wondering whether that's the correct topic, because looking at your program today, it's an amazing program covering an extraordinary range of topics. And I'm not sure if my lecture shouldn't be one on how Australian trainees can come and spend some time in Pakistan, Turkey, and the Emirates to get some surgical experience. But nevertheless, I'll talk to you about training in Australia and opportunities for overseas trainees to study here. So that's just who I am and where I work. I'm at two hospitals, the Princess Alexandra Hospital and the Greenslopes Private Hospital. And when I travel to overseas conferences or I'm chatting with international trainees, I usually get asked these questions. Is there any chance of being able to work in our unit? Can young trainees get some training in Australia? And how does the neurosurgery training program work in Australia, and how is it different to here? So I'll look at these three topics in three ways today, and my talk's divided into these three parts. And the first part is the training of graduates from Australian medical schools to become neurosurgeons. In other words, what is the neurosurgery training program in Australia? In Australia, there are 21 medical schools across the country. Almost all of these are government or public. Only one of them is private. 9 schools take graduates directly from high school. The other 13 schools, the graduates have to come through a university course and then into the medical course. It's important to understand that all the medical schools are comparable. They're almost all equal. And a graduate from the medical school will come out with the same qualification as someone else elsewhere in Australia. Now, do Australian medical schools accept international students? Most Australian medical schools will accept international students. They generally have to pay full fee places, and they generally have to sit an MCAT exam, which is an exam in English proficiency. The medical school I'm associated with is the University of Queensland Medical School, and it's very typical of an Australian medical school. So if an international student comes to Australia and attends the medical school here, how much will that cost? In Australian dollars, it's between $75,000 to $90,000 a year. So a total medical degree will range somewhere between $300,000 and $600,000. Excuse me. So international students who studied in Australian medical schools, can they progress to become a neurosurgeon in Australia? Well, they can, but it's an uncommon pathway. The pathway to being a neurosurgeon in Australia is in itself complicated and confusing, and I'll go through that now. So for an Australian medical student, once they've graduated, to get to be a neurosurgeon, they would generally do 1 year as an intern. They would do 1 to 5 years accumulating criteria to allow them to enter the neurosurgery training program called the SET program. They would complete the SET program over a 5 to 9 year period, and then they would need to pass an exit examination set by the Royal Australasian College of Surgeons. So for someone to train in any type of surgery in Australia, there are generic criteria. And the first is that they would require permanent residency or citizenship. So for a foreign student studying in a medical school, then wanting to go on into SET training, at some stage they would need to achieve permanent residency or citizenship to progress to full training. What is the training program in neurosurgery? So once the students become a doctor, the doctor then has to finish their intern training and then develop themselves towards being selected into neurosurgery. And the minimum that they have to have is some training in a neurosurgery unit, experience in intensive care. They have to have published articles and they have to have done presentations at our meetings. Once they've accumulated enough of this criteria, they're then eligible to sit a neurosurgery anatomy exam, and their referees' reports from their units are assessed. When all of this is taken into account, we generally end up with about 50 or 60 applicants per year, of which the top 30 will progress to an interview. Out of that interview phase, there will be somewhere between 5 and 10 candidates selected each year from all around Australia and New Zealand to progress to train in neurosurgery. So about 5 to 10% of the applicants end up doing neurosurgery. Now, what about the program itself? So once they've entered the training program, they have to spend at least 5 years doing it, and they can't take longer than 9 years. There's 3 levels of training that they have to get through, and their training is done at accredited posts throughout the country. The trainees are allocated to these posts, and they have to attend a minimum of 3 different training posts in the country. They can't stay in one hospital in one training post for their 5 years. At the end of their set training, if they're deemed eligible to, they then have to sit the fellowship examination. And this is taken towards the end of their term. It comprises written and clinical and viva components, usually 2 written papers and 5 of the clinical and viva segments. It's essentially an exit examination at setting a certain standard that everyone has to get to allow any surgeon to be registered in their specialty and for a neurosurgeon to be registered as a neurosurgeon. So in summary, neurosurgery training in Australia is undertaken by the Neurosurgery Society of Australia. The Royal Australasian College of Surgeons is responsible for all the training. They allocate to the Neurosurgery Society of Australia the responsibility of training neurosurgeons to become fellows of the college. The federal government has very little say in any of this. It appoints people to what's called the Australian Medical Council. The Medical Council reviews the College of Surgeons every 3 years to make sure that the standards are maintained and up to date. It appoints members to a medical board so that when a person is deemed suitable to sit the RACS exam, pass the RACS exam, the medical board can register them as a neurosurgeon and then oversees their behaviour whilst they're a neurosurgeon into the future. So one way to become a neurosurgeon in Australia for a foreign graduate or a foreign student is through the medical school system, but that's a long and arduous one. The second way in which foreign neurosurgeons can be trained in Australia, and the one that's most applicable to the talk today, is for short-term training in neurosurgery. This is a pathway for a specialist international medical graduate, i.e. an overseas trained specialist, or somebody towards the end of their training who can come to Australia and get advanced training in this country. So it's a short-term pathway. It leads to more advanced training or subspecialisation, but it doesn't allow registration at the end of the training period. To be eligible for this, an international graduate has to have a basic degree recognised by the world authorities and the Australian Medical Council. They have to have done their training or be within 2 years of finishing their training. But the crux of everything, the most important part, is they have to have secured an offer of a position in Australia prior to applying to the board to come here. So the key to any foreign graduate or foreign neurosurgeon wanting to train in Australia is to first of all secure a position in a recognised neurosurgery unit here. Then they apply to the Medical Council verifying their qualifications. Then they apply to RACS with their application, with their MBA accreditation and the place where they are going to train. RACS then reviews the accreditation of the unit and the accreditation of the candidate, and if they agree that all is fine, they will notify the medical board, and the IMG can apply to the medical board for limited registration. So, an international medical graduate finds a hospital and a position and a supervisor to work in. They then apply to the Medical Council to verify their degree that they can come here. They get both of those and apply to RACS. RACS reviews the hospital and reviews the candidate, and if they say it's all fine to come and train in that position, you apply to the medical board, and the medical board will give you limited registration to train here for 1 to 2 years. So how does that work in Australia? There are 502 neurosurgeons in Australia. There's 1 neurosurgeon per 50,000 people. Many Australian neurosurgeons only practice spine surgery. There are 27 neurosurgery training units with 56 training positions. Nearly all of these training units will have fellow positions for IMGs. I'm not sure what the total number would be, but it would be at least 20 or so around the country for IMGs. Interestingly, comparing Australian neurosurgery to the nations involved in the Neuro Conference, my understanding is Pakistan has 300 neurosurgeons, or 1 per 800,000. Turkey has 1,500 neurosurgeons. I was surprised with that, which is comparable to Australia. And for the Emirates, I wasn't able to get a figure for the number of neurosurgeons there. My hospital, Princess Alexandra Hospital, is a typical neurosurgery unit. 8 neurosurgeons, 3 trainees, 5 non-training registrars. And we have 3 positions for fellows from overseas. Skull base, a functional movement disorder gamma knife position, and a spine position. Our hospital caters to all the subspecialties of neurosurgery. We're an 800-bed hospital to 1.5 million people. 30 beds, about 1,200 operations a year, fairly typical for Australia. So that's for short-term training in Australia for fellows. The final way in which somebody can train and become a neurosurgeon in Australia is for a specialist international medical graduate who wants to come to Australia, live here, and be a neurosurgeon here. So this is a specialist pathway for people interested in working permanently as a specialist in Australia. There are 2 streams, but the majority of people are looking for specialist recognition. Now, the key to getting into this pathway is to get an individualised assessment. So an assessment of comparability to the Australian standard. So the general requirements to do this pathway are you need a primary medical degree from a recognised institution. You need to have been trained as a specialist neurosurgeon, to have proficiency in the English language, and then you verify all of this through the Australian Medical Council, and then you write the RACS, and RACS reviews all of this, and they grade the applicant as compared to an Australian neurosurgeon. So there is a comparability to an Australian neurosurgeon. So the applying neurosurgeon will be graded as not comparable. So in other words, they would not be able to train or work in Australia. Partially comparable, which is what the vast majority of applicants are deemed as, or substantially comparable, which means that the training and expertise is comparable to Australia and New Zealand. 2 years of supervision and then passing the exam. So in conclusion, in summary, an overseas neurosurgeon who's assessed as partially comparable has to find a hospital to work in. They have to find a fellow position. They have to go through sub-training and then have to pass the fellowship exam at the end, and then deemed to be suitable to join the RACS and fellowship community here. The substantially comparable neurosurgeon shows the same thing, but they will usually be able to show that they've set an exam comparable to the RACS fellowship. Now, in summary, this is quite difficult, and the only areas where, or only places where this is really seen is if you've sat the Royal College of Surgeons, or through Edinburgh, or perhaps through some of the American institutes. And to be able to show your surgical qualification is of a standard to meet the Australian Fellowship examination. So for a substantially comparable person, they may need to have some clinical assessment, and again, the most difficult component is finding a suitable unit and a supervisor. So in summary again, for a substantially comparable neurosurgeon, they again have to find a hospital with a position to be assessed in. If they're assessed as being substantially comparable, they may need to do a little bit of training and then be approved for fellowship. The key is finding a position in Australia. So I've rushed that a little bit, but we're a little bit over time anyway. So in summary, in answer to the 3 questions at the start, is there any chance of being able to work in a unit in Australia? Yes, in my unit, we already have 3 fellow positions. Is it possible for young trainees to get training in Australia? Yes, it absolutely is. And I hope that I've given you some not quite so complicated understanding of the neurosurgery training program in Australia and how it would be different to your local area there. Foreign medical students can study in Australian medical schools, graduate and become neurosurgeons. We've had Canadian, Malaysian and Chinese people do this. Short-term training in neurosurgery is available, and Said will talk to this later in a talk later today. Specialist international medical graduates in neurosurgery can qualify to be neurosurgeons and practice in Australia, but it's a relatively arduous pathway. In summary, all of this can be done, but the most difficult component of getting training in Australia is finding that fellow position in the hospital, which you have to find first, in a suitable neurosurgery unit with a supervisor. If you can find that, then you can go on and get the other components towards successful training. All of the information that I've provided this morning can be found on the Royal Australasian College of Surgeons website or on the APRA website. These are some useful links that I can send through to anyone. I would like to acknowledge one of my resident in one of the hospitals I'm working in at Greenslopes Private Hospital, Dr. Kirat Ul Ain Saeed. Kirat comes from Rawalpindi. She trained as a paediatrician in Pakistan, and then her husband moved to Australia and she came. She is presently trying to go through that specialist pathway to become a paediatrician in Australia, and she helped me quite a bit with this talk. So, thank you very much for allowing me to present today. It's a great honour to present for this memorial lecture. I apologise once again that I cannot be there in person. I'm sure it's a wonderful conference. A special thank you to Professor Raja and best wishes to everyone for a successful conference going forward. Thank you for allowing me to present today.
Thank you, Dr. Olson. Thank you so much. And one of your students is here, Dr. Saad bin Anis. He wants to talk to you.
Hey, good day,
Yes.
Dr. Hall. How are you?
Well, very well, thank you, Said, and thank you for this opportunity once again.
Sorry for the logistical delay, and I must present my heartfelt gratitude for joining us today and presenting this very valuable information to us. My main objective was to, make a bridge from Pakistan Society of Neurosurgery towards Society of Neurosurgery Australia. I'm not sure how much successful I am going to be, but I think it's a baby step. And many of the young, enthusiastic neurosurgeons would definitely be looking forward to contact you and other neurosurgeons. So I hope they will find good matches just like I did. I was lucky enough to have you guys. Thank you.
Saeed, thank you. You did a wonderful job, and the bridge is well and truly made. Both myself and Sarah speaking today, it's a great honour. And we'd be very happy to continue this relationship with yourself, with the Pakistan neurosurgeons, but also you have Turkish and Emirates people involved in this meeting, and there's no reason why they shouldn't make applications as well, which we would very much welcome. So thank you once again.
Dr. Asif, you wanted to say some words?
I don't think he can hear from here.
No.
Professor Hall, can you hear me?
Okay, come here.
Sorry?
So, Professor Hall, it was an honor to have you speak and give the Bashir Memorial Lecture. In fact, my name is Asif Bashir. We haven't met, But Professor Qasim and myself were the co-hosts for this lecture, and we are both Professor Bashir's sons. Saad, I was just talking to him. I didn't know that he went to fellowship for you, but he has an extremely bright future because this is the change which we expect. You know, I have come back from US, people like Saad and all these people are training outside and they are changing from inside out. That is what will make the difference. So again, gratitude, and we would love to have you come and visit Lahore, Pakistan and see, in fact, the largest training program in the world right now with over 80 residents in neurosurgery at Punjab Institute of Neurosciences, which was started by Professor Bashir. So thank you so much for finding the time.
Thank you once again.
Thank you so much, Dr. Hall, for your time. And thank you so much, Dr. Asif and Dr. Qasim, for chair the session. I would request Professor Ahmad Ali Shah and Professor Tariq Khan to chair our next session. The president is Professor Dr. Sarah Olsen from Australia.
Hello.
How are you, Dr. Sarah? Can you hear us?
Yes, great, thank you.
Okay, thank you so much for joining us.
No, thank you so much. Yeah, for the wonderful invitation, I'm honoured. I am very much sad that I'm not there in person. For having Saad here, if you're all as clever and capable as him, I really wanted to meet you all. So last time I joined, I was during COVID, and it was extremely helpful. I was taught how to inversely drape a microscope, and that was before COVID hit Australia. So that was very, very helpful. So as you know, Saad has been with us for a year, and this was the first laser case we did in the Southern Hemisphere. We've done quite a few since, and Saad was with me all the way. It has been great to have him, and of course having a much younger spine to check the art during DBS. So we did a lot of DBS, gamma knife and laser together. And of course I'm very much missing my wingman in our philosophical discussions. So talking about futility in surgery, this is my friend Ali and Virginia Maxner. They're separating twins from Bangladesh. It wasn't to say it was futile. It was a wonderful operation. They did very well. But it was considered that in Bangladesh. And that, I think, gives us an idea of how slippery this term is of futility. So this is a patient from more than 20 years ago that haunts me. You know, we all have our patients that haunt us. So he was a 21-year-old who jumped off a roof into a pool. He missed. He hit his head on the concrete. His GCS was 5. It deteriorated to 3 with a fixed pupil. I was there in emergency. We moved him straight through with fixed dilated pupils to surgery. I don't think I would do anything different today, but 8 months later, and now more than 20 years later, he's in a persistent vegetative state. And the charge nurse says to me, I blame you for operating on him. The family are very difficult, but of course, they have to have someone to blame, don't they? You know, it was extremely difficult situation. And I wonder what we're really helping people with. Is it we're going through the grieving process? We can't do that in that split second when somebody is dying, but we certainly can help them afterwards. Can do, should do. That's a very different question. Now, when I gave this talk in America, I realized that it's quite different. I think your system in Pakistan is similar to ours. We have a public system and we have a private system where people can either pay for an operation or they've got their own insurance. But in America, they're only paid if they operate. So discussions on futility were somewhat challenging there. Really, I started thinking about this, as I think all of us did during COVID, because we had rationing. We suddenly had extreme pressure on our ICU beds, and we really had to think about, were we doing the right thing, or were we just doing the things we'd always done? And was it really right to operate on this person and put them in ICU? And maybe I should actually face up some much more difficult thoughts and discussions. So generally we have a Medicare system. We have equal care for equal need. It underlines the universal health system, Medicare. We're not a preserved life at all costs. We would generally try to balance ethical principles of beneficence and non-maleficence. So what does futile mean? Well, futilis was a useless vase. It had a very narrow bottom and wide top. It was only good for ceremonial occasions. It was leaky, vain, failing of the desired end through intrinsic defect. One hopes they're not talking about the doctors when they describe that. Hopelessness cannot be confused with futility, as that's an emotional response. It's not an objective determination. Rationing can't be confused with futility, as it's an attempt to optimize limited resources, as we saw in COVID. Futility is a determination made regarding a course of action for an individual patient. There's a natural inclination to survive, which really inhibits patients and their families making logical end-of-life decisions. This is amplified when you've got a proxy decision maker involved. You know, they're confounded by guilt, by grief. Really having an advanced healthcare directive is very helpful to all involved. There's a fallacious belief you can beat the odds. We are risk adverse when presented with a situation that involves sure gains, but risk seeking when you're presented with sure loss, like in glioblastoma. There's a societal expectation that you must do everything to save a patient, and an erroneous belief in the omnipotence of medicine. People believe we're actually better than we actually are. There's a rule of rescue, which of course is probably applicable to that young man I described. We want to help people, we want to save them. This is what sees people go into burning buildings after people, or people jump into raging waters after a lost sailor. And surgeons have to focus on cure from a technical standpoint rather than seeing the whole picture. We are aggrieved when we did a technically perfect operation, but somehow the patient doesn't work out quite as we expect. We don't have the training, time or inclination in how to discuss non-operative planning and guide patients through difficult processes of end-of-life care. Desperate families really appreciate nuances, and so you've got to be very careful in your language. Should you even discuss unproven interventions? So if we go back in time, the Hippocratic Corpus included a promise to avoid medical treatment in patients overmastered by their disease. To attempt futile treatment is to display an ignorance that is allied to madness. Platonist Republic said, for those whose life are always in a state of inner sickness, Asclepius did not attempt to prescribe a regime to make their life a prolonged misery. A life with preoccupation with illness and neglect of work is not worth living. Now, who would say that? Now, you know, that is a demonstration, I think, of the slipperiness of this term. I think somebody who doesn't have a family, doesn't have children, that was definitely Plato. So it's been said that madness is doing the same thing over and over again, expecting a different result, like Sisyphus, who again tries and tries to fulfill his task, fully aware of his absurd situation. He cannot get that rock up the hill, it just keeps rolling back down. A little bit like us, I suppose, in glioblastoma surgery. But it is said that the fight itself suffices to fill the heart of man, and one must imagine Sisyphus happy. So you have to be happy trying to get more and more of this tumour out, all the while knowing that we're not actually going to cure the patient. And you actually wonder, well, is it also mad, but perhaps we're also a little bit stupid? So definition, the physiological is whether a treatment is efficacious. Quantitative is the number of survivors. Qualitative is the one we really want. And that is the one that is difficult to get. One of the fundamental problems in fertility is that the term is very value-laden. And most physicians know fertility when they see it. Really is a little, probably arrogant, implies semantic slipperiness and subjectivity. When doctors were interviewed in Brisbane, there's an overwhelming preference for a qualitative approach to managing patients. So we've got a real problem in Australia and most of the world, I think, and we've really got to get our head around it. We've got an ageing population, increased treatments are available, and our spending's out of control. So it's just going up and up and up. Becoming old is a real privilege that really results from improvements in a healthcare system, and the expectancy now is 85 to 90 years of age. But we're not really thinking about that from a surgery perspective. We haven't got a dedicated focus on that to the overall healthcare burden associated with that. By 2017, the population over 60 is expected to double. And the net effect of that is to increase real costs by 17.1 billion in today's dollars just to maintain where we are at today. And there are lots of problems. Recognising beliefs and values within certain cultures and religions, many of whom feel life is sacrosanct and should be preserved at any cost. As our medical culture has placed a premium on patient autonomy, given the wide-ranging moral and cultural beliefs, identifying a universally acceptable quality outcome really isn't possible. The patient autonomy movement has arisen very strongly in Australasia. I'm not sure, in Pakistan I'd be keen to hear, but into abuses probably that took place during strong physician paternalism. As a surgeon, I believe I can't impose my beliefs and biases on a patient. They may not fit with their context of life, but I think we all have to remember we're still the most informed person in the room who can help the patients make that decision. There are unrealistic expectations. For example, CPR on television. Everyone survives, don't they? That lies amplified in the media as miracle survivors when all doctors said there was no hope. Physicians feel pressured to provide aggressive care for a desire to do something as doing nothing is not tenable. Does that remind you of Sisyphus? A UK study showed that 11% of patients in ICU were receiving care that was considered completely futile. So, oh well, that's the NHS. Interestingly, in America, it was pretty much exactly the same, so very different system. Well, that can't be the same in Australia, surely. It's exactly the same. 12.1% of ward and ICU beds had patients that were having treatment perceived as futile, costing an extraordinary amount of money. In an Australian study, people over 65 and over who were in their last year of life used an estimated 10.3% of public hospital days and accounted to 89% total inpatient costs, with 40% in the last month of life. You wonder how we could have managed that better. I'm not going to talk about financial reimbursements. It's not so much a problem in Australia. And of course, you can never say never. Even if you see B follow A 1,000,000 times, you cannot be absolutely sure the same thing will happen again. And how many times and to what degree do we have to fail before we say a treatment's futile? Is it cruel or inhumane to offer life-sustaining treatments in whom the intervention is deemed futile? I do think we would all of dignity and purpose if we had to do do what we perceive to be futile. But a compassionate act such as waiting for families to arrive in intensive care before removing ventilator should be distinguished from an obligatory act. Of course, we do that frequently. And of course, futility is used in a clinical scenario to justify a physician to unilaterally withhold or withdraw treatment, even over the objections of a competent patient. And this creates a very adversarial interaction. Should the clinician be the ultimate arbiter, or are we merely extensions of a patient's will? Patients hate the word futile. What they hear is cost-cutting and rationing. And I do think there is something very paternalistic about that term. Patients and their families may grip for options to reverse life-threatening illnesses, which may lead practitioners to feel compelled to offer treatments that are not yet proven. They may feel a technological imperative to use those interventions when they exist. They may fear legal action, and they're practicing defensive medicine. They just have to continue the mindless continuation of aggressive treatments, again, like Sisyphus. There is a tension between the value of autonomy and the desirability for a more Spartan approach to the consumption of medical resources. Now, I really like this cost-effectiveness ratio. This was mathematical, it appeared to me, and people who argue for it say it's ethical to decline treatment if the treatment would be harmful to the patient or would be harmful to others, potentially through consuming limited resources in the public health sector. The costs of intervention are divided by the benefits, setting up a cost-effective ratio. Choosing a less expensive treatment simply means more patients are able to be treated, and it would favour more effective treatments. But there are concerns about equity in healthcare, which can be raised if there is a care discrimination on the basis of patient age or bias regarding quality of life. Others, though, argue, due to limited resources, it is acceptable under the construct of social justice to direct care to those most likely to survive. This is definitely most useful, I think, when you're in a rationing situation and played out with COVID. But it has been argued that as a society, we're on the slipperiest of slopes if we permit ourselves to withdraw life support from a patient simply because it would save money. So can the law help us? Well, the law actually doesn't really want to get involved. There is no requirement for a physician or other medical practitioner to treat a patient when considered at odds with their medical judgment or violates their personal ethics. Fear of litigation puts that patient-physician relationship in significant jeopardy. Interestingly, when physicians have withdrawn support against family wishes, courts will side with the medical professionals. But if you ask for it before you do it, courts will side with the family. But they are really quite keen, the legal system, for hospitals to come up with their own processes for internal resolutions of futility disputes. Sorry for the busyness of this slide. I was just looking over how we manage this in different countries. We've only really had one case in Australia, and where relatives sought an order from the Supreme Court for treatment not to be withdrawn. But the Supreme Court dismissed this under pari passu jurisdiction, where the court has a right to act in the for the benefit of the patient. It was very straightforward. There was no prospect of meaningful recovery, severe hypoxic brain damage. So that really wasn't a big thing. But in the US, they've had some serious cases. The case of Helga Wangley was an 86-year-old in a persistent vegetative state. As she was court-ordered to remain on a respirator, her husband said the doctors weren't God. Only God could take his wife. And so for many months, she remained on a respirator. In the Schiavo case, this young woman had a cardiac arrest secondary to hypokalemia. There were 25 court rulings over 10 years. After 15 years, a Florida Supreme Court judge ordered the feeding tube removed despite the Vatican's intervention and, at the time, Jeb Bush's intervention. Baby Kay was an anencephalic infant whose mother demanded complete care, and the US Court of Appeals upheld that hospitals must continue life-sustaining treatment. It must be very difficult, I think, for nurses, doctors to look after these patients. When I came to Australia, in New Zealand, we couldn't remove feeding tubes in patients who are palliative. And I felt distinctly uneasy about it because we could in Australia, and I really had to distance myself from that. Interestingly, I didn't notice at the time, but in the US and in UK, termination of an artificial feeding and hydration requires prior sanction of a High Court judge. And But now there's a growing international consensus in clinical medicine bioethics that removing nutrition and hydration in appropriated cases should be done. In my state, it gets even more complex, where we have a Guardianship Act, and there have been difficulties in patients who are lacking capacity. If a doctor decides that there should be an NFR order, that must go to the public guardian or to the family, and it nearly ended in a nasty law case. What about the church? Well, the Catholic Church says there's a doctrine of ordinary and extraordinary means, and individual autonomy is not absolute. If it's extraordinary, it's morally optional. If ordinary, then morally mandatory. And treatment must be objectively proportionate to the prospects of improvement. I will be very interested to hear how the Quran is interpreted and how this is managed through religion in Pakistan. Ethics committees, well, really, if they're at the same hospital, it's difficult to be unbiased. And to be honest, it's thought that really they probably lack sufficient knowledge to be managing these decisions. So what do we do when we don't know? We look to the literature, but there are problems with that. Decompressive craniectomy, as we know, was said to be favourable outcome for patients, but they included an MRS of 4/5. So 4 is 4 or below, sorry. So moderately severe disability, you can't walk on your own or attend your own bodily functions. So an alternative interpretation is that surgery actually is more likely going to cause poor survival. What about this? Evacuation of acute subdural hematoma. So 27% can still go on to have a favourable outcome, but they included 4 again. That's a poor outcome. What about this in the UK? Saying that 12% of these older patients had a functionally independent outcome, but the other 88% did not. And just the costs for the emergency surgery was $100,000, not including any ongoing costs, and that is difficult to reconcile. Futile recanalization in stroke is actually the rule, not the exception. So we're trying to work out exactly who will benefit and who won't. Frailty indices and risk calculators are very helpful. How do we go with solutions? Well, I like this philosopher, Pellegrino. He focused on futility as a method for determining what's right and good healing action for a particular patient, weighing the treatment's effectiveness. Only we can communicate that. Only the patient can say what benefits there are to them. But the burdens, that's a shared clinician and patient discussion. Goals of care discussion really probably need to be discussed before that situation is reached. Risk calculators, AI, electronic health records, and big data have the potential to help us where we really haven't had that before, where you could just plug in and a 79-year-old acute subdural GCS6, fixed dilated pupil, no past medical history, 4 hours to surgery, what is the likely outcome? And you could plug that in and give that to a family, and that would be, I think, very helpful. Advanced healthcare directors are extremely helpful, I believe, to families who find it very, very hard to make decisions when they're in this situation. We do need to think more about geriatric surgery. It's really becoming a very much an area all on its own. And obtaining other opinions, patients really value that. I think particularly, as I've said, you are the most informed person in the room, but it's easier when you are of the same culture and beliefs, I think. For example, if I said to my bank manager, what mortgage would you choose for yourself? Well, I believe what he told me. But if I asked a young man what he believed would be the best car for himself, I'm pretty sure that would not be the same car as I would choose, because I would have different beliefs as a mother of 3 children. So other things that, of course, Atul Gawande focused on was, you know, asking patients of what is your understanding of where you are, what your illness is? What are your worries for the future? What are your goals? What outcomes are unacceptable to you? It will be unacceptable to me to be dependent. What would a good day look like? Well, for me, that would be out in the sun with my family. So all these things can help people make a decision on where they're going. And if a patient's not likely to benefit from major or minor surgical intervention, should they even come to hospital? This is a problem with our ageing population. We have not caught up with this. So they all end up in hospital and then we can't work out where to put them from there. We need to think about palliative care services coming in from the start. I do think, actually, as surgeons, we need to have a potential shift in training and practice. Need to have some training in palliative care. As I said, is to cure sometimes, to relieve often, but to comfort always. And we do need to see the bigger picture. And it is actually okay to die. So I published this in World Neurosurgery, and I was very happy with the reviewers, particularly to hear my writing described as elegant. As it's the only language I have, I'm sure my English teachers would be happy with that. Thank you very much.
Thank you so much, Dr. Sarah, for giving us your precious time. And we miss your presence here in the NEUROCON 36. Over to Professor Ahmed Ali Shah Saab and Dr. Tariq Khan Saab.
Thank you, Dr. Olson, for a very impressive lecture. We doctors generally don't want to play God in these situations. And I was in UK 2 years back when I had COVID and was admitted to a hospital. And over there I found out that the NHS has entire record of the patient. And there are clear indications in that record. Do not resuscitate depending on the patient's age and his comorbid. So at least for the older patients, they are very clear. Thank you.
Some people might view that as ageist, and some of those people might say, well, I've paid my taxes, why am I not eligible for this treatment? You know, there is that bias, I think. You know, that's, again, looking at cost effectiveness, I think, which is appealing, very appealing. But whether it's fair and ethical, I'm not sure.
Thank you, Dr. Sala. We are having a short of time, and we have the prayer time also. So the last topic, I thank you, Professor Ahmed Ali Saab and Professor Tariq Saab. We chaired this session. And the final session, the topic of the session, for that, I will request Professor Naveed Ashraf and Professor Samina Khalik to come on the stage and chair the session. And the talk is from UK. Yeah. Actually, Dr. Irfan Malik was also supposed to come here, but unfortunately, he has a bad runny nose and sinusitis, so he couldn't. And even in the morning when I called him that your lecture is on this time, again he told me that his condition is not in a properly, so he just gave his talk to his friend. One of his friends is giving this talk. Hi, hello.
Hi, very sorry, my screen, it cut out a second.
Yes.
I'll just share the screen.
I'm Dr. Riaz, the Chairman Organizing Committee, and for this session, the chairs are Professor Naveed Ashraf and Professor Samina Khalik, and we are thankful to Dr. Irfan Malik. Because of this, his condition, he gave you the talk, so proceed. Thank you.
Hi, good morning from the UK, from London. I hope you can hear me and see the screen. My name's James Knight. I'm presenting on behalf of Irfan Malik, who is a little bit unwell. I believe he's online, but unable to present. At King's College, we looked at back pain outcomes in lumbar decompression. So the co-authors are down here on the right. I was the lead author on this, and we looked at the British Spinal Registry and looked at patient outcomes for back pain. I'm sure most of you know registries are national registries where cases and outcomes are reported nationally and anonymized. And we have a British Spine Registry that's been running for about 14, maybe 15 years, and there's over 100 centres through the UK that upload their data to that. This slide looks a little busy, but it's actually quite straightforward. Our inclusion criteria for the study was we looked at the lumbar degenerative pathway, and we included those with posterior approaches for laminectomy or discectomy. And we excluded anyone that was having revision surgery, any deformity, anyone having fusion. We didn't include any pediatrics. This means we also excluded spondylolisthesis. So this was simple lumbar decompression for either lumbar canal stenosis or for disc herniations. And at baseline, we had just over 25,000 patients. And because we were interested in back pain, we obviously didn't include patients that reported no back pain. And you'll see at this middle box here that 92% of the patients had back pain at baseline. So it was only slightly less than 8% that only had leg pain. So the vast majority of patients with canal stenosis or disc herniations have back pain also. Practice in the UK is that surgery is typically only offered for patients with associated leg pain, so canal stenosis with claudication or disc herniations with radicular symptoms. It's very rare and not standard practice to offer operations for back pain alone. So these are all leg pain patients, but 92% also had back pain. And we looked at a number of time intervals. At the bottom, we had those with 1 year follow-up, which was nearly 8,000, those with 6-month follow-up, which was 9,000, and those with 2-year follow-up, which was 5,500. What I'll show you shortly is that the outcomes at 6 months, 1 year, and 2 years are the same. So it's valid to combine them as one group. So that's a combined analysis on the left, which is any patient that has follow-up at least a time point of 6 months, 1 year, or 2 years. So that gives us nearly 12,000 patients over a decade in the UK. Just for comparison, the Swedish registry paper in 2013, that was a very comprehensive paper looking at various things, but they also included lumbar laminectomy and discs and had about 3,700 patients. The Canadian registry paper in 2019, which looked at exactly the same thing as we're about to look at, had just over 1,000 at baseline, 677 at 1 year. So as a comparison, at baseline, we had 23,000. We had nearly 8,000 with the 1 year follow-up, as we've just been through. But as a combined analysis, we had 11,745. It's a large observational study. And just to be clear, the main thing we looked at was patient-reported outcomes for back pain. So I'm sure most of you know the visual analog scale, often called VAS, and it's just where a patient marks on a line from 0 to 10 where their pain lies. And for this database, they log their back pain, their worst leg pain, and their best leg pain. We were obviously analysing predominantly the back pain. And they log that prior to surgery, and then they log that at various follow-up points after surgery. And this is ultimately the outcome. This slide tells us pretty much everything we need to know from the study. We will look at it in more depth, but in simple terms, this is the outcome. You can see the top distribution plot or density plot is the back pain VAS score at baseline, so prior to surgery. And the bottom one is at follow-up at 1 year. And the two colours are pink and this light blue is just splitting them into whether they were a laminectomy group or a discectomy group. So the no discectomy group will be those that are having simple laminectomies or hemilaminectomies for canal stenosis. And those having a discectomy will be either laminectomy plus discectomy, or a laminotomy, or a hemilaminectomy, or interlaminar decompression. But we split them into either they were having a discectomy or not, with various approaches for the posterior decompression. And you can see at baseline, the vast bulk of patients have a VAS at baseline pain score of somewhere around 7.5 up to 8. So the bulk of the patients have significant back pain, with a long tail then with less patients having minimal back pain. And if you operate on these patients by either taking out their disc herniation or decompressing them, it shifts at 1 year, where they're predominantly way down here at 1 out of 10 with minimal back pain, and then a long positive tail. Clearly there are still some patients that have back pain, but there's a shift in the distribution down to a minimal back pain. This is the patients with 1 year outcome. I'm going to show you a graph for 6 months and 2 years, which will look almost identical because the outcomes are the same at 6 months and 2 years. So this next one is the 6-month graph, which looks pretty much the same. And this next graph is the 2-year outcome. And if you flick between the three quickly, you'll see that they very slightly change, but that's not a meaningful difference. So it was completely valid for us to then combine these as a combined analysis of 6 months plus 1 year plus 2 years. The problem with these distribution plots is, though they tell you all the information you need for the patients, they're very hard to actually explain to a patient or to summarize in one line. You can't write this in a clinic letter or put it in a consent form. But it does tell you all the information you need to know. If you want to relay this to a patient, there's a few other ways which we'll go through. You can explain by saying what the mean pain scores are, so the mean visual analog score. And here, again, we've got the two colors for discectomy or no discectomy. And again, you can see that they're pretty much the same. And at each time point, there's a very, very narrow 95% confidence interval. And along the bottom, we've got the various time points. So baseline, you can see that the mean score is up at around 7, 6.6. And then at 6 weeks, it drops to around 3, 3.5. And at 6 months, 1 year and 2 years, the majority of those gains are maintained. So you can use mean to explain things to a patient. The problem with means is that most patients aren't a mean. What is particularly useful about this graph is that it shows you that the gains that are made in back pain are present as early as 6 weeks. And this is why I think this graph is particularly useful. But there is actually a consensus internationally on how we should report pain outcomes. This is the impact recommendations, which is in the Journal of Pain, and it's a consensus expert opinion on how to report pain outcomes. This isn't particular to back pain or spinal problems, this is just pain in general. And what they advocate, when you're using a 0 to 10 or a 0 to 100 type of scale or numerical scale, such as the visual analog scale, it's much better to report the percentage reduction in pain. An example is if you're 8 out of 10 and you reduce to 6 out of 10, you reduce by 2. But going from 8 out of 10 to 6 out of 10, the patient might not feel that's very meaningful. Whereas if you're 4 out of 10 and you drop to 2 out of 10, it's still a drop of 2, but actually your pain is halved. So a percentage is a much better way for patients to express or to quantify their pain reduction. And what the impact consensus did is they looked at a number of very large pain studies that then anchor statements. They use the anchoring method with the percentage reduction. The anchor statements that allows the patient to qualify with a verbal statement of how much better they feel. And that gives us this blue table, which is ultimately what we used as the main outcome measure for our study. You can see that they've got the categories of 15%, 30%, and 50% reduction in pain. And the anchoring statements from their consensus meeting is that if you have a 15% reduction, patients will say, well, it's noticeably better, but it's not that significant. It's not really made much of an impact on my life. Once you get to a 30% reduction, that's when patients start to say that they feel much better. Once you get to a 50% reduction, patients will say that they have a substantial improvement in their back pain and they're very much improved. So the one that we should be reporting is the 30% reduction in pain, which is what they categorize as the minimum clinically important difference in pain reduction. So 30% reduction is the cutoff that says an intervention is meaningful and useful. So then looking at this graph with the categories that we've just clarified of no improvement, minimal improvement of 15%, the important improvement of at least 30%, and then a substantial improvement of 50%, we've got this plot that goes from 0 to 100% with the 6-week, 6-month, 1 year, 2 years, and then the combined analysis. As a reminder, the combined analysis is the 11,700 patients that had follow-up at least 6 months, 1 year, or 2 years. And in dark blue, you can see that they have a substantial, this is the proportion of patients having a substantial improvement in their back pain. They are patients that say they feel very much better. They have at least a 50% reduction in their pain. And you can see that in nearly all groups, it's around 50% reduction. So at 6 weeks, there's quite a large jump, but some of them then regain back pain by 2 years. But overall, it's about 50% of patients will have a substantial reduction in their back pain, so they feel very much better. When we include 30% or more, that's the next category of blue, and you can see that it's about 2/3. So the take home from this would be that about 2/3 of patients having lumbar decompression for discal stenosis, 2/3 would say that they are significantly better at follow-up. They have a meaningful improvement in their back pain, they'll say they feel much better. What we then wanted to look at is, well, what about patients who have a pain predominance? So some patients will have leg pain and back pain, but will say their back pain is worse. Some patients will say their leg pain is worse, and some patients will say that they're both equal. So when you break them into 3 groups of back pain predominant at the bottom, neither predominance in the middle, or leg pain predominant at the top. For example, a leg pain predominant would be 8 out of 10 leg pain, but 5 out of 10 back pain. And a back pain predominant would be the reverse of that. And we wanted to know if patients coming to you prior to surgery had a predominant back pain with some leg pain, but mainly back pain, would they still show improvement in their back pain following decompression? And we can see that the substantial improvement is still at 50%, and the meaningful improvement, 30%, is still at around 2/3. You could actually argue that if your back pain predominant is slightly more likely to have an improvement in your back pain. So clearly, patients who are predominantly back pain, as long as they also have some leg pain and also have some neuronal compression, if they're predominantly back pain, it's not necessarily valid to suggest they won't improve with decompression. What we finally looked at was, well, what about severity of back pain? So there are patients that will have a 5 out of 10 back pain. There are patients that will have obviously 10 out of 10 back pain. We wanted to know if the patient has 10 out of 10 back pain, will they still improve? And you can see whether you have 5 out of 10 pain, 6 out of 10 pain, or 10 out of 10 back pain, you still have the same overall improvement. So the blue is the patients that meet the minimum improvement of 30%. And you can see that the values are pretty much the same across the board. Obviously, the group with 1 out of 10 pain have less reduction, but then they have very minimal back pain at the start. So it's the severity of back pain doesn't necessarily mean that they're less likely to improve. So the takeaway from this is that if you're seeing a patient with back pain and they're having a lumbar stenosis or a lumbar disc herniation and they are having a decompression and they want to know, will their back pain improve? Historically in the UK, we used to tell them that it's not an operation that helps back pain. It could be worse, it could be better. If they have very severe back pain, we are more apprehensive of offering them these surgeries. And there is definitely a consensus among some surgeons that if they're predominantly back pain or have very severe back pain, that maybe a fusion with decompression will be more appropriate. Whereas we've found that 2/3 of patients will report a meaningful reduction of 30% or more in their back pain. And that's at 6 months, 1 year, or 2 years. Those improvements are found as early as 6 weeks. Secondly, if you have predominantly back pain, you're just as likely, if not slightly more likely, to have those improvements in your back pain. And thirdly, with increasing severity of back pain, it does not reduce the chances of you having a meaningful recovery in your back pain. If you're 10 out of 10 back pain, we still find that they have the same chance of having an improvement in the back pain as if you're 4 or 5 out of 10. So I think this potentially changes the way we counsel patients and consent patients for surgery. I think we're definitely not advocating that decompressive surgery is a treatment of back pain. These are all patients that have neuronal compression, and they're all patients that have leg pain. But it's a way of changing our view of how their back pain may improve. And it maybe does challenge the belief that if they have significant back pain or predominant back pain, whether a fusion is or isn't needed, it maybe challenges that idea. And that's effectively it. So I'm happy to take questions or comments. This was published earlier this year in the Journal of Neurosurgery with the authors that we listed at the start. And we were all from King's College, London.
Thank you very much. Thank you very much, Dr. James Knight, for a brilliant lecture. And thank you once again for not letting us feel the absence of Dr. Irfan Malik. Secondly, the long-held belief by most of the neurosurgeons, and obviously those who are dealing in spine surgery, was very scientifically substantiated by your study, and probably we would feel much more confident in counseling our patients about the long-term outcome of lumbar decompression surgeries. If there are any comments, or yes, please.
Sir,
Thank you very much.
I can hear you distantly. I'm not sure if there's any questions or comments.
It's more of a comment, Dr. James. Thank you so much for representing Dr. Irfan, who is a very good friend of mine as well. And we had been together for quite some time here in Pakistan. It's just, I think there is a paradigm shift. We know that we don't treat symptoms, we treat diseases. Backache is a symptom. Now, how do you actually justify that? I feel a little uncomfortable because here there are some junior doctors who are sitting trainees who would be getting a message that perhaps we would be operating on backaches. We are not treating backaches, we are treating a disc disease or whatever you think it is, because we have to make a diagnosis and then start treatment. Just a symptom would be, perhaps it's very difficult to swallow as far as I'm concerned.
Yes, so definitely not advocating for the treatment of back pain via surgery. What we're trying to do is, if patients have a lumbar stenosis or a disc herniation and they're going to have surgery because of their leg pain, we were trying to quantify, which they often ask, what's the chances that they'll have an improvement in back pain? And so this allows us to help counsel the patients in regards to their leg pain and back pain. And it possibly helps us be a little bit more optimistic that they're very likely or possibly going to have an improvement in their associated back pain. But we're not treating back pain, and we completely agree. What we're saying is these are already patients with a significant lumbar canal stenosis or a significant disc that are presented with leg symptoms that warrant surgery. When they subsequently ask about their back pain, this maybe helps us quantify the chances of that improving.
Okay, well, thank you.
Perhaps, thank you very much, but perhaps Dr. Amjad Shad would like to offer a comment.
James, hi, it's Professor Shad. I work in West Midland. I think we need to be careful. Have you analyzed the back pain we're talking? Are we talking claudican back pain, which does improve after the decompression? A lot of patients I see with the L5S1 disc prolapse will complain of the buttock pain, which patient will describe as a back pain. And that does improve after the discectomy. So I think we need to analyze your result further. Are we talking of claudican back pain, mechanical back pain, instability pain, or back pain due to the irritation of S1 nerve root and sometimes L5 nerve root, which does improve? What will happen is with this analysis, people will use this as a license to treat it for back pain.
Yeah, I completely agree. So we also in the paper tried to postulate reasons for improvement in back pain, and it depends on why you have back pain. It's important to note that we excluded deformity and spondylolisthesis. We're doing another study on spondylolisthesis. One of the papers we quoted in our introduction in our main article was that when you ask patients about back pain and leg pain and then ask them a year later, they often get mixed up between back pain and leg pain, and this is felt to be due to it being buttock pain or gluteal pain, that the patients can't really articulate whether they're seeing that as a leg pain or a back pain. So one of the reasons may be that patients are seeing this as back pain, whereas in fact it's radicular pain, as you just said. Another reason we postulated was whether the neuronal compression is also referred pain, because of course some of these will be L4-5 and some of them 3-4 and even L2-3. And so it may be that the neuronal compression is giving them some back pain, and when you relieve that neuronal compression, the back pain is resolved. Clearly, 2/3 of patients still, 1/3 of patients, still have back pain, and they're going to be patients that have multifactorial back pain, maybe have some instability, have associated musculoskeletal pain. So again, it's not an advocation for treatment of back pain, but it's and the reasons why their back pain get better, as you say, multifactorial, and could be because they're mistaking referred pain as back pain, or we don't fully know. It could also be medial facet, if people are taking some of the medial facet, whether that's relieving some of the pain. I think there's multiple options.
That's correct. I think we need to do further analysis on the subgroups. Is it the focal back pain which is improving, which might? Are we talking about the diffuse myofascial type back pain, which indirectly can improve due to the improvement in the posture once the leg pain improves? So I think that will be an interesting analysis. Thank you very much.
Thank you, Dr. James, and thank you, Dr. Naveed Ashraf Saab and Dr. Samina for chairing this session. There are a few announcements. Number first, the Society's executive lunch is in the museum. When you go from downstairs, you see on the right side, there's a museum. There is a security officer's office in the museum. So the executive committee should proceed there for their lunch and there for their meeting. Second thing, I am happy that all the papers are within the time. So we concluded at the 1, and now this is the break for the namaz and lunch. But what happened in the morning, the presenters came late, that's why we have to quit their papers. Now, if those presenters who doesn't present yet, they should inform us. Meanwhile, at this time after the afternoon or tomorrow, we will adjust them, okay? And this is just because of their entrance into the sessions late. It was not from our side. So our state of our session started from 11 o'clock from the time, and they are now ending at the 1 o'clock. So proceed for the namaz and lunch. Thank you so much. After the namaz at the 2 o'clock, kindly come back to this hall, Latif Hall, and we have the another sessions, keynote lectures, and very good discussions on the many topics of the neurosurgery. Thank you so much.